Dear colleagues, welcome to the fourth annual OncoAlert Colloquium presented by OncoAlert and our esteemed partners at the American Society for Radiation Oncology, the European Society of Surgical Oncology, the European Society of Gynecological Oncology, MASC, the International Association of Supportive Care in Cancer, SIOG, the International Society of Geriatric Oncology, and the OncoAlert Consortium, which is made up of 12 medical oncology societies from low and middle income countries. Today, we bring you the top of 2023 in breast cancer. Our presenters are Dr. Erika Hamilton, ER-positive metastatic breast cancer, Dr. Stephanie Graff, HER2 metastatic breast cancer, Dr. Hope Rugo, advanced triple-negative breast cancer, Dr. Maryam Lustberg, early triple-negative breast cancer, Dr. Matteo Lambertini, ER-positive early breast cancer, Dr. Evandro de Azambuja, HER2 early breast cancer, and our ESO session, Dr. Giuseppe Catanuto with surgical breast cancer oncology in 2023, and our Astro session with Dr. Icro Meattini in the best of 2023 breast cancer radiotherapy. And we finish off with Ms. Janice Cowden, patient advocate and OncoAlert faculty with the patient advocate perspective. So now, without further delay, Dr. Hamilton.
Hello, I'm Dr. Erika Hamilton, and I lead the breast cancer research program at Sarah Cannon Research Institute in Nashville, Tennessee. On behalf of OncoAlert Colloquium, I'm happy to present advanced hormone receptor positive breast cancer and some of the newer developments. So first, these are my disclosures. This is to say that we do a lot of clinical research, but I take no personal funds from pharma. Briefly, we're going to be talking about novel endocrine backbones, moving towards endocrine resistance and the new targeted agents in combination with endocrine therapy, and then finally finishing with antibody drug conjugates for patients with ER-positive breast cancer that have hormone resistance. So first, let's talk about the different mechanisms of action for these approved ER targeting therapies. So in column A, all the way on the left, you can see this is how estrogen typically interacts with the estrogen receptor. It binds, it goes into the nucleus, and ultimately affects gene transcription and downstream signaling for growth and survival of the cancer. In column B, aromatase inhibitors work by preventing estrogen in the body. This works for postmenopausal patients since their ovaries are no longer making estrogen, and also works for premenopausal patients that are pharmacologically postmenopausal with drugs like LHRH agonists. In column C, you can see that these are SERMs. SERMs bind the estrogen receptor. They're shaped a little bit differently. Ultimately, they cause a conformational change, and this results in not allowing downstream signaling. These are the compounds that can be agonistic in some tissues and antagonistic in others. And then in column D, you can see that these are the SERDs, or selective estrogen receptor degraders. They are also shaped differently. They bind the estrogen receptor and ultimately flag it for degradation. And so I explain this to my patients as we're chewing up and spitting out the estrogen receptors. So let's go through the Emerald trial. This study led to the approval of elacestrant, which is our first oral SERD to be approved in the metastatic setting. So this was a phase 3 trial of elacestrant versus standard of care endocrine therapy. Patients had progressed or relapsed after 1 to 2 prior lines of endocrine therapy. They had to have received a CDK4/6 inhibitor in combination with one of those lines. And so what did these patients look like? Very few of them really had received chemotherapy. About half had ESR1 mutations, and about 45% or so had received 2 prior lines of endocrine therapy. Most of these patients did receive fulvestrant in the control arm, and again, this was randomized head-to-head against elacestrant. In the top left, we can see progression-free survival among all comers. This was statistically significant, but I think a lot of us were maybe a little bit disappointed in the magnitude of benefit. This increased progression-free survival from 1.9 up to 2.8 months with elacestrant. Now, in the bottom right, when we select for those patients that have ESR1 mutations, those that are more likely to still be dependent on the estrogen pathway, more likely to be endocrine sensitive, we can increase the magnitude of this benefit 1.9 months up to 3.8 months. If we look at this in a little bit more of a complex fashion, you see that the entire top of the slide represents all patients going from left to right. The bottom of the slide are those that have ESR1 mutations, and then the different columns are the duration of benefit on their previous CDK4/6 inhibitor. So at least 6 months, at least 12 months, or at least 18 months. And if you see on the bottom two panels, if we're selecting for patients that have ESR1 mutations and have received at least 12 or 18 months benefit with their CDK4/6 inhibitors, our benefit of PFS for elacestrant is really essentially almost 8.5 to 9 months. So I think if we pick or select for these patients that are more likely to still be endocrine sensitive, we can get a higher magnitude of benefit. What other data have we seen from oral SERD? This was the SERENA-2 trial with camizestrant. This is a little bit of a similarly designed trial, but they did look at 2 different doses of camizestrant, both 75 milligrams as well as 150 milligrams. And it was a very simple design up against fulvestrant alone. Patients had no more than 1 line of endocrine therapy in the advanced breast cancer setting and no more than 1 chemotherapy. If we look in the bottom left about patient population, you'll note that not everyone had seen a CDK, only about 50% of patients. ESR1 was detectable in really kind of more along the 35 to 40% of patients, and most patients did have visceral disease. In terms of progression-free survival, we saw that whether we're looking at 75 milligrams or 150 milligrams of camizestrant, that this did significantly outperform fulvestrant. So fulvestrant with 3.7 months of PFS, and camizestrant 75 and 150 in the 7 to 8 month range. You can also see that this did complete accrual. There is a phase 3 trial evaluating camizestrant with palbociclib as well, and we will be hearing more about this compound. So really, what are the advantages or differences of oral SERDs versus standard endocrine therapies that we already have? We certainly have aromatase inhibitors. We already have the injectable form of a SERD, fulvestrant. Well, oral SERDs, in terms of the side effects they do have very mild GI toxicity. Aromatase inhibitors can have many more side effects in terms of arthralgias, sexual side effects, worsened bone mineral density and osteoporosis, hot flashes, etc. And fulvestrant also has injection site pain. What we do see with some of the oral SERDs is bradycardia, so a lower resting heart rate. This certainly does go up with activity. I have not seen any patients have any ill effects from a lower resting heart rate, and this goes away when we stop drug. Or we also can see photopsia. This is a little bit confusing. This does not change patients' baseline vision. It doesn't prevent them from driving at night or reading or seeing well. It really is just a little bit of the waffling of the vision at the periphery when ambient light changes. So you can think turning on the light in the morning or switching off your nightstand lamp at night. Again, very tolerable for patients, and I've not seen many patients have issues with this. So there are phase 3 trials with oral SERDs, camizestrant and giredestrant in combination with CDK4/6 in the first line. There are also adjuvant oral SERD trials ongoing, as well as second line trials against drugs like fulvestrant that we still haven't seen the results of. So what about another twist on endocrine backbones? These are PROTACs, or proteolysis targeting chimeras. They degrade the target protein here, the estrogen receptor, via the ubiquitin proteasome system. They're catalytic, meaning that once they've degraded one estrogen receptor, they can move on and affect another one. So potentially this leads to less toxicity and a higher therapeutic index. And so you can see here in the diagram, the PROTAC is our little rainbow molecule. Our target protein, the estrogen receptor, is in green. This brings in E3 ligase, it ubiquinates it, flags this protein for degradation, and ultimately the proteasome gets rid of this. ARV-471, vepdegestrant. This was the phase 2 cohort expansion of the VERITAC trial. You see patients having at least 1 prior endocrine therapy for metastatic disease. They must have had CDK4/6 inhibitors and up to 1 chemotherapy, and looking at 2 different doses in an expansion of ARV-471, the PROTAC. Again, patient population, you see everyone has seen CDK. 3/4 have seen fulvestrant, almost half have seen chemotherapy, and baseline ESR1 mutations sit right at above 50%. What we see is clinical benefit rates, depending on whether we look at all patients, a little shy of 40%, or among those with ESR1 mutations, a little shy of 50% in terms of clinical benefit rate. And in terms of progression-free survival, a little bit of a similar story, 3.5 months for all patients at the recommended phase 2 dose of 200 milligrams once daily. But again, if we enrich for those with ESR1 mutations, this does lengthen up to 5.5 months. We really see adverse events that are only grade 1 and grade 2. There were no dose reductions due to adverse events at 200 milligrams, and only 2 patients discontinued drugs due to adverse events. So definitely this gestalt that this is an easy drug for patients to tolerate. So now that we've talked about backbones, let's talk a little bit about targeted agents. We've seen a lot of movement in targeted agents over the past several years in ER-positive breast cancer. This is the newest data. This was out of December 2023 at the San Antonio Breast Cancer Symposium. This is inavolisib. It's a selective PI3 alpha mutant inhibitor. It is 300 times more selective for P110A over other P110 isoforms. And this was the study design. And I really want to point out some differences in this study because this isn't your average patient in the first line setting. So one, everyone had a PI3 alteration. And this was central by ctDNA or a local tissue or ctDNA test. So again, everyone had PI3, and these were patients that progressed very quickly within adjuvant endocrine therapy. So they progressed either while on their adjuvant endocrine therapy or within 12 months. So we have a population of quick progressors that also have a PI3 kinase alteration. And patients were randomized either to fulvestrant palbociclib. Again, remember that fulvestrant is the appropriate backbone here, as these patients relapsed within 12 months of their AI, or fulvestrant with palbociclib and inavolisib. So this is what we see in terms of progression-free survival. It's a doubling, PFS of 7.3 months up to 15.0 months. And you see some snapshots at 6 months, 12 months, and 18 months of who's progression-free. So on one hand, these PFSs seem low. So remember, our PFS with CDK4/6 inhibitor in the first line setting should be around 2 years. But again, when we talk about patients that have a PI3 alteration, as well as these incredibly high risk patients that relapse while on their adjuvant AI or within 12 months, this is what we see, that this is really a very poor prognosis group. So on fulvestrant palbociclib, only getting about 7 months PFS. So to see this increase to 15 with a hazard ratio of 0.3, certainly significant. You'll also see duration of response up in the top left, also significant. And then in terms of the overall survival analysis, the hazard ratio is 0.64, but the pre-specified boundary for OS was not crossed at this interim analysis. This is still very early data. I anticipate that we'll see updates in this. Now, what about in terms of adverse events? We struggle sometimes with the PI3 kinase inhibitors. We do see stomatitis or mucosal inflammation in about half our patients. Grade 3/4, more rare, less than 6%. We do see an improvement in hyperglycemia compared to drugs like alpelisib. We had pretty high rates of grade 3/4 hyperglycemia with alpelisib. You'll notice here that, again, this is less than 6%. Diarrhea happens in any grade, about half of patients, but again, less than 4%, more severe grades. And you'll see that we've also really knocked down rash. Only about a quarter of patients having any rash, and no cases of severe rash. So this isn't perfect, but this is certainly a lot better in terms of tolerability, I think. And in terms of discontinuations, which I think is very telling of how patients truly tolerate, we did see discontinuations only in about 6% of patients receiving inavolisib and 0.6% on the placebo arm. So it appears that most patients were able to tolerate this. So what about another targeted agent in this pathway? This is an AKT inhibitor, capivasertib. This was Capitello 291. These were for patients that recurred while or on within 12 months of adjuvant aromatase inhibitor or progression while on prior aromatase inhibitor for metastatic disease. Less than 2 prior lines of endocrine therapy for advanced breast cancer, less than 1 line of chemotherapy, less than or equal. And patients were randomized essentially in the second line setting, either to fulvestrant with placebo or fulvestrant with capivasertib, the AKT inhibitor. Interesting dosing schedule. This is 4 days on, 1 week off. And what did these patients look like? We see about 40% of patients had alterations in the AKT pathway. So this is PI3, AKT1, or PTEN. About 70% of patients had seen prior CDK. Only about 18% had seen chemotherapy. What we see was a statistically significant improvement in PFS. Again, fulvestrant alone, PFS 3.6 months up to 7.2 months with fulvestrant with capivasertib. And if we select for those patients that had AKT pathway altered tumors, this benefit is even higher, a hazard ratio of 0.50, and the benefit 3.1 months up to 7.3 months. So again, this drug is going to be an option. It is now approved in the United States, at least, capivasertib for those patients with alterations in the AKT pathway. Now, what about overall survival? This is not statistically significant at this point. Hazard ratio is a 0.69, still crossing 1. You can, again, see overall patient population or AKT pathway alterations, and this was approved on November the 16th, again, by the FDA here in the United States. So what about our patients that have received maybe 1, maybe 2, maybe up to 4 prior lines of endocrine therapy, but are now endocrine resistant, not getting benefit with a reasonable PFS for the endocrine therapy that they're trying? This is a situation that we really think about moving on to chemotherapy. And now for ER-positive disease, we also can consider some antibody drug conjugates. This is Destiny Breast 04. I think many of you are quite familiar with this trial. It was for patients that had HER2 low expression, and it really accepted patients that were either ER positive or would have classically been defined as triple negative. You'll note in between the 2 randomization boxes here that 480 out of the 600 patients did have hormone receptor positive disease. Only 60 had triple negative in this HER2 low expression. So this was a trial where the majority of patients were hormone receptor positive, and they had had 1 to 2 prior lines of chemotherapy in the metastatic setting. So you see about 2/3 of patients, a little over 2/3, had seen prior CDK4/6 inhibitor. 2 prior lines of chemotherapy was less frequent than 1. And about 2/3 of patients had seen at least 3 prior lines of therapy for metastatic breast cancer. So this was an update from ESMO 2023 that's in the red box. And so now with a follow-up of 32 months for those patients with hormone receptor positive disease, which is the purpose of this presentation, our progression-free survival had lengthened from 4.2 months up to 9.6 months. When we add in these triple negative patients, these additional 60 patients, and go to the right side of the slide, we see really a quite similar benefit, 4.2 months up to 8.8 months. In terms of overall survival, the update at 32 months, we now have 17.6 months versus 23.9 for hormone receptor positive. Functionally, this is overall survival from 1.5 years up to 2 years. And if we go over and add in our triple negative patients that have a little worse outcomes, you see the hazard ratio is identical, 0.69, but the PFS is a little bit shorter. Overall survival is a little bit shorter, 16.8 months, now up to 22.9 months, so just a little bit shy of a year. This is a 31% reduction in the risk of death for these patients receiving a HER2-directed antibody drug conjugate for HER2 low compared to single-agent treatment of physician's choice chemotherapy. In terms of adverse events, it's important to remember that all of the ADCs are not created equally. Although they all are maybe in the same category of drug, they have very different side effects. Far and away, our most common side effect with trastuzumab deruxtecan is nausea. Really about 3/4 of our patients experiencing nausea. Now remember that when Destiny Breast 04 and Destiny Breast 03 was enrolling, mandatory antiemetic prophylaxis was not required. So at least in my clinic, I think we're functionally doing a lot better with this. Now that the NCCN has categorized this as moderately emetogenic and recommended at least a 2, if not a 3-drug antiemetic regimen up front in a prophylactic fashion for these patients. So in my clinic, patients get an NK1, a 5-HT3, such as ondansetron, as well as steroid, and patients are doing very well in terms of nausea. We do see less neutropenia with TDXD compared to single agent chemotherapy. And you can see that alopecia rates are actually pretty similar. In terms of ILD pneumonitis, this was a concern with this drug due to fatal cases of ILD pneumonitis initially, with more recommendations around when to hold. We hold even for grade 1 asymptomatic ILD now. We discontinue drug for grade 2 or higher. We've really been able to cut down on this. We still see any grade ILD pneumonitis in the 10 to 14%, depending on what study we're looking at. But you can see here that fatal cases of pneumonitis is at about 1%. And we do have some studies now where it's closer to 0%. So very important to pay attention to ILD pneumonitis here. This was approved by the FDA in the United States for HER2 low in August of 2022. So what about another version of an antibody drug conjugate? This is sacituzumab. It is targeting TROP2. It's similar in design to trastuzumab deruxtecan in the term that it has a higher DAR, a drug to antibody ratio of about 8. It also is one of our newer generation antibody drug conjugates. And so this was TROPiCS-02. It was a phase 3 trial of sacituzumab versus treatment of physician's choice single agent chemotherapy. Patients had to have hormone receptor positive disease. They had to have had a CDK4/6 inhibitor and at least 2, but no more than 4 prior lines of chemotherapy. So a tiny bit more pretreated, had to have had at least 2 lines of chemo here. This is what we see in terms of progression-free survival, a improvement in 1.5 months, and this was statistically significant. And in terms of overall survival, we also see an improvement in overall survival here, hazard ratio of 0.79, 11 months up to about 14 and a half months. And this received FDA approval in the United States, February of 2023. One of the questions that have come up is, okay, well, we have a HER2 targeting antibody drug conjugate. We have a TROP2 where we aren't testing for TROP2. Is there a population within this TROP2 that may not receive benefit? For example, if you're HER2 low, do you get benefit out of sacituzumab, or is maybe that really limited to those that don't have HER2 low expression? And this analysis was done, and you can see that really irrespective of HER2 low or HER2 null or 0, patients are receiving benefit from sacituzumab govitecan. This shouldn't be surprising. I think we pretty well put to rest that HER2 low is not a new breast cancer subtype. It's simply a biomarker. Patients with HER2 low expression don't have differences in how they do in drugs, how they do overall in terms of survival, or any really pathological characteristics. In terms of safety, again, I'm highlighting that different antibody drug conjugates definitely have different side effects. Counts is a big side effect issue with sacituzumab govitecan, especially that we're giving it on day 1 and day 8 every 21 days. So we certainly have to keep track predominantly of neutropenia, although we certainly do see some anemia as well. Diarrhea also pretty prominent with sacituzumab govitecan. 62% of patients having diarrhea and 10% having more severe diarrhea and fatigue as well. So what about our newer antibody drug conjugates? This is not currently approved. This is Dato-DXd. It's also TROP2 targeting, but it has the exatecan DXd payload from trastuzumab deruxtecan. And again, optimized DAR here is about 4, also has bystander anti-tumor effect that we have come to expect with the DXd payloads. This was TROPION-Breast01. This was also presented just several months ago at ESMO 2000, and it was a phase 3 trial of Dato-DXd versus investigator's choice chemotherapy, eribulin, vinorelbine, CAPE, or GEM. Everyone had hormone receptor positive disease, and they'd been previously treated with 1 to 2 prior lines of chemotherapy. Now, remember, when we count the lines of chemotherapy, we're already taking into account that they'd been through endocrine therapy, progressed on that, deemed endocrine resistant, moved to chemotherapy. So this is not total lines. This is 1 to 2 prior lines of chemotherapy. This was progression-free survival, 4.9 months with chemo, 6.9 months with Dato-DXd, a hazard ratio of 0.63. And in terms of side effect, again, this one looks a little bit different. We do see nausea like we do with trastuzumab deruxtecan, but stomatitis is a more prominent side effect among about 50% of patients. Again, when this trial was enrolling, there was not prophylactic mandated steroid mouth rinse, which we know can help stomatitis. So we need to tease out exactly what this rate is if we do use a steroid mouthwash in a prophylactic fashion. We do see less neutropenia than chemotherapy. And so this certainly is encouraging as well. And ears tuned for more information on this drug. So where do we currently sit for ER positive metastatic breast cancer? Oral SERDs are active as monotherapy. We've had 2 positive trials, so far 1 drug approval in the metastatic setting, and it's also active in combination with CDK4/6 inhibitors and an increasing body of literature really with other drugs such as PI3 kinase inhibitors, et cetera, anything that we can combine with endocrine therapy. Activity does appear more pronounced among those patients that have ESR1 mutations. Hard to say whether this is really just a surrogate of patients that are more likely to be endocrine sensitive. I certainly have numerous patients in my phase 1 clinic that have received years benefit of oral SERDs that do not have ESR1 mutations. They have a pretty tolerable side effect profile. It's definitely going to be interesting to see when we put them in the adjuvant setting and really report out on these trials, how it compares with aromatase inhibitors, because we know that sometimes side effect profiles reporting can be a little bit different in the metastatic setting versus in the adjuvant setting when conceivably these patients may be cured. And again, these currently are in the adjuvant setting and enrolling. So a great opportunity for us to be hearing more information in coming years. Novel endocrine agents like Protax may have some advantages over oral SERDs in certain spots. They appear active in patients that might have already had oral SERDs, maybe patients that have a little bit more endocrine resistance, and the toxicity profile seems a little bit different. Endocrine resistance due to PI3, AKT, mTOR pathway activation. We now have 3 drugs here. We have alpelisib, we have capivasertib, and both of these are approved. And then we also have recent data of inavolisib. This is not yet approved, just reported a little over a month ago. And we also have newer antibody drug conjugates with potent payloads. 2 currently approved targets are HER2 and TROP2 in patients that have hormone receptor positive disease. And interestingly, particularly for TROP2, appear to be active regardless of biomarker expression. And somewhat of a similar story we're now seeing with trastuzumab deruxtecan, certainly active in HER2 positive, active in HER2 low, and now we're testing even HER2 null and HER2 ultra low. So kind of asking the question of how low we can go. It's certainly an exciting time. Our overall survival for patients with hormone receptor positive breast cancer is now over 5 years, and we aim to make this much better. Thank you.
Hi, my name is Dr. Stephanie Graff, and I'm the Director of Breast Oncology at the Legaretta Cancer Center at Brown University in Providence, Rhode Island. And I'm proud to be presenting for OncoAlert today, Metastatic Breast Cancer for HER2 Positive Disease, the Year in Review from 2023. Just some key highlights from the year really focus on Destiny Breast 03 long-term follow-up, as well as HER2 Climb 02, but we'll get into some other key publications and abstracts presented throughout the year. Starting with Destiny Breast 03, published in Lancet at the start of 2023. So Destiny Breast 03's big update was a long-term update, which provided median progression-free survival, strongly favoring trastuzumab deruxtecan over TDM1 for second-line metastatic HER2 positive breast cancer, compared to TDM1 with a median progression-free survival of 6.8 months. TDXD significantly improved median progression-free survival to 28.8 months for an unparalleled hazard ratio of 0.33. Similarly, we saw overall survival significantly improve with a hazard ratio of 0.64, although the endpoints were not reached. Subgroups across the board strongly favor trastuzumab deruxtecan, including notably both hormone receptor positive and hormone receptor negative cohorts. Although patients were only eligible to participate in Destiny Breast 03 if they had stable or previously treated brain metastasis, those who were known to have brain metastasis equally benefited from the addition of trastuzumab deruxtecan on subgroup analysis. Moving to HER2CLIMB-02, presented at San Antonio in 2023 by Dr. Hurvitz. HER2CLIMB-02 randomized patients in any line of therapy to TDM1 plus tecotinib versus TDM1 plus placebo. Patients were eligible who had stable, progressing, or untreated brain metastasis, which was a stratification variable. When we look at the patient characteristics, which were well balanced in the treatment arms, we see that about 43% of patients did have the presence of brain metastasis, including about 22% of patients having active brain metastasis. And when we look at the line of prior systemic therapy for patients, about 13% of patients enrolled in HER2CLIMB-02 had no prior lines of therapy in the metastatic setting. The majority, about 64%, were receiving HER2CLIMB-02 as their second-line treatment, and still others were enrolled on HER2CLIMB-02 as third-line therapy and beyond. I think this is important as we think about how HER2CLIMB might fit into our treatment paradigms. Although DESTINY-Breast03 allowed patients who had progressed within 6 months of therapy on neo or adjuvant therapy, only about 1% of the patients that were accrued had 0 prior lines of therapy in the metastatic setting. And we see, of course, here in HER2CLIMB-02, it's a higher N for that population. HER2CLIMB-02 median progression-free survival did reach statistical significance with an improvement in progression-free survival from 7.4 months for TDM1 plus placebo to 9.5 months for TDM1 plus tecotinib. Across subgroups, the progression-free survival favored the addition of tecotinib to TDM1, including those with baseline brain metastasis, whether or not they had received prior lines of therapy, which when we look specifically at that population, they seem to get a slightly higher hazard ratio, more favorable hazard ratio at 0.51 with the addition of tecotinib plus TDM1 than the total population. Additionally, whether or not they had hormone receptor positive or hormone receptor negative breast cancer. Overall survival is immature. Additional follow-up will be needed. And subgroup analysis of the population with brain metastasis, again, favored the addition of tecotinib, improving progression-free survival from 5.7 months to 7.8 months, with a hazard ratio of 0.64 for the addition of tecotinib to TDM1. Safety analysis shows us that the addition of tecotinib came with a slight increase in adverse events, which is anticipated by adding a second chemotherapeutic. And the side effects are perhaps classic for what you would expect with the addition of tecotinib, including nausea, diarrhea, fatigue, vomiting, AST and ALT increases, and then down the line. Just to flash back to HER2CLIMB, so that we don't get HER2CLIMB-02 and HER2CLIMB confused. HER2CLIMB, which was published in Annals of Oncology in 2022, I'm showing here, looked at tecotinib versus placebo in combination with trastuzumab and capecitabine. In this trial, we saw that tecotinib, in addition to cape plus trastuzumab, improved median progression-free survival from 4.9 months to 7.6 months, and also improved median progression-free survival from 19.2 months to 24.7 months, both of which were statistically significant. And so I think as we think about how tecotinib is going to fit into our treatment of HER2-positive metastatic breast cancer, one of the questions that remains is, will it be better to use TDM1 and tecotinib in sequence or in combination? And what the best combination partner for tecotinib will be, if it is in fact TDM1, or if it's better to use it in combination with capecitabine. And what will the final overall survival analysis of HER2CLIMB-02 be? As it stands right now, we do know that HER2CLIMB, tecotinib plus capecitabine plus trastuzumab, improves overall survival. And so we want to see that additional analysis mature for the HER2CLIMB-02 regimen. So right now, how I treat HER2 positive metastatic breast cancer, first line standard of care remains Cleopatra, trastuzumab, pertuzumab plus a taxane. Up and coming in the wings, trials that are ongoing include Destiny Breast 09, which is randomizing patients to TDXD with or without pertuzumab versus taxane, trastuzumab, and pertuzumab in HER2 positive metastatic breast cancer. Additionally, HER2CLIMB-05 is ongoing, which adds tecotinib at the point in Cleopatra where the taxane is dropped and a patient is maintained on trastuzumab and pertuzumab maintenance. Patients are randomized to the addition of tecotinib as a part of their maintenance care. And we will wait for the results of that study as well. Current standard of care in the second line, NCCN category 1 recommendation is TDXD based on the results of Destiny Breast 03. Of course, other options include HER2CLIMB. I did include HER2CLIMB-02 there. That comes with the caveat that I do think we need to wait on overall survival data to mature, and of course, some additional regulatory language to help with some of the financial barriers and payer barriers. But I think, and also given the inclusion criteria for HER2CLIMB-02 for patients that have rapid progression, for patients that have contraindications to some other lines of therapy, HER2CLIMB-02 may have some flexibility across the treatment landscape to give our patients a highly effective therapy across every line of treatment. And the third line, current standard of care is tecotinib based on HER2CLIMB. Again, I added HER2CLIMB-02 there as well. Again, I think we need to wait on overall survival data to mature. TDM1 also remains as a standard of care third line option. If not utilized in third line, fourth line options include TDM1, tecotinib if it has not been used yet, I should add. Trastuzumab plus any number of combination partners, including lapatinib, chemotherapy partners, neratinib, and margetuximab. So total change of topics here. I'm going to move into the Insider's Guide to Interstitial Lung Disease. Through 2023, we saw numerous updates based on the available data that we have on interstitial lung disease as a side effect of note with trastuzumab deruxtecan. And I think some of the reviews and abstracts that were presented were really important for us to know about as clinicians and just top-notch reviews. So I want to bring this to everybody's awareness. First, at ASCO 2023, Ian Kropp presented a pooled analysis of interstitial lung disease and pneumonitis by age. This pooled analysis included data from Destiny Breast 02 and Destiny Breast 03. And what we saw was that patients were, when they looked at the adjudicated rate of interstitial lung disease or pneumonitis, that patients over the age of 65 were more likely to develop interstitial lung disease than patients under the age of 65. I think that this may inform clinical practice when you're trying to make decisions about how frequently or closely to monitor your patients, as you may consider an age as an additional variable in how frequently to do screening lung imaging. At ESMO Breast in 2023, Dr. Hope Rugo presented some limited data on retreatment in patients after grade 1 interstitial lung disease. As it stands right now, the only patient population that is appropriate to offer retreatment to is patients with grade 1. Again, grade 1 interstitial lung disease are patients with a radiographic infiltrate that is clinically asymptomatic. These are patients who really you would only detect by doing screening lung imaging, or who had, staging studies that randomly detected lung infiltrates without the patient having any symptoms. 6 patients had grade 1 interstitial lung disease and were retreated after resolution of the radiographic abnormality. 1 patient had recurrent grade 2 ILD, and the other patients went on to, as you can see here, tolerate retreatment reasonably well with a reasonable duration of therapy, including some patients receiving it for 600, 800, 1,000 days, which is obviously clinically meaningful for these small N. I think this gives us some data that we can discuss with patients in clinic. Just to call out a few great papers that you can keep flagged. Dr. Tarantino published in JAMA Oncology a great review, interstitial lung disease induced by anti-ERBB2 antibody drug conjugates, that includes some algorithms on monitoring, confirming, and managing interstitial lung disease. Dr. Rugo and colleagues published in a Journal of Clinical Oncology, Oncology Practice, the real-world perspectives for interstitial lung disease. Similarly, it has some excellent tables and graphics looking at recommendations for monitoring, corticosteroid dosing and treatment, imaging recommendations, and how to think about what defines worsening or progression of disease across grade 1, grade 2, and grade 3, grade 4 interstitial lung disease for patients being treated with interstitial lung disease, including some great algorithms. And lastly, Dr. Tarantino, again, and colleagues in JCO Oncology Practice published the 5S rules for detecting and managing TDXD-related interstitial lung disease, which includes screen, scan, synergize, suspend treatment, and steroids, which has some really helpful ways to think about and approach interstitial lung disease. I think that these are all fantastic reviews as we think about management and screening of a potentially fatal outcome of a really important therapeutic that we're readily utilizing in our clinical care. Moving to the X7x7 trial and DTORCH, of course, neither of these studies are unique to HER2-positive metastatic breast cancer, but given that I have time to cover them in my time today, and the wealth of new data that are available in triple-negative breast cancer and hormone receptor-positive breast cancer, I wanted to make sure that my other OncoAlert faculty had time to cover what they needed to, and that these were raised to a conversation. Capecitabine is, of course, a partner of trastuzumab, and so I want to include it in our conversations today. So Dr. Kumar Khan presented the X7x7 trial at ASCO 2023, and this trial included patients with any metastatic breast cancer, including HER2 positive, but also triple negative or hormone receptor positive, and stratified them one-on-one to either what was called fixed dose capecitabine or standard dose capecitabine. Standard dose capecitabine in this schema was capecitabine at 1250 milligrams per meter squared twice a day for 14 days on, followed by 7 days off. And fixed dose capecitabine was 1500 milligrams twice a day, not per meter squared, just 1500 milligrams flat twice a day for 7 days on, followed by 7 days off. 80 patients were randomized to the fixed dose arm, 73 patients were randomized to the standard dose arm. Primary endpoint was 3-month progression-free survival, and secondary endpoint included progression-free survival, overall survival, and objective response rate. Just for point of comparison, in HER2 CLIMB, the capecitabine dosing is 1,000 milligrams per meter squared. So the standard dose used here is slightly higher than what we use in HER2 CLIMB, but the standard dose here is what is utilized in, for example, CREATE-X, which is another commonly prescribed oral capecitabine regimen that we're utilizing in the breast cancer field. Progression-free survival in the 2 arms for the fixed dose was 8.7 months, and in the standard dose was 12.07 months. So overall, relatively similar. The p-value is 0.98. We don't have yet a peer-reviewed publication of this abstract, and these are relatively small numbers. So clearly not a non-inferiority design. So it's hard to know if, based on an abstract, really how similar this would be if designed with much higher N and a little bit more balance between the various different types of breast cancer. But I do think that this gives us some helpful data that as we personalize care for our patients, that we can offer a high degree of flexibility in how we are rapidly dose modifying our capecitabine to make the drug as tolerable as possible for our patients. Moving to overall survival, again, with the fixed dose, median overall survival 19.8 months. For the standard dose, 17.5 months. Log ranked p-value 0.17. When we look at the subgroup analysis, the subgroup analysis is pretty on the middle of the plot, suggesting that the fixed dose and the standard dose are relatively similar. There's a few arms where the standard dose does seem to pop over to favor, including the HER2 positive group and possibly the visceral metastasis group. Overall, however, notably the toxicity is much lower for patients in the fixed dose, with a 2.5% risk of grade 2 to grade 4 diarrhea versus a 20% risk with the standard dose, 15% risk of hand-foot syndrome in standard dose versus 3.8% risk with the fixed dose, and a substantial reduction in mucositis from 5% to 0%. Speaking of hand-foot syndrome, also at ASCO 2023, DTORCH was presented, which was a presentation from Akhil Santosh, which looked at randomizing patients to a topical application of diclofenac, which was a 1 gram, 1% twice daily topical diclofenac to both hands during 4 cycles of capecitabine, versus a twice daily application of a matched placebo. Patients were randomized 1-to-1 who were on capecitabine. And what we saw was that the addition of the topical diclofenac substantially reduced the rate of hand-foot syndrome. This is grade 2 or higher hand-foot syndrome, and it reduced the rate from 15% to 3.8%. But notably, not only did it reduce the rate of hand-foot syndrome, but we also saw that in total, patients were able to tolerate the drug better, and it led to less dose reduction. Thank you for your time today and for allowing me to review some of the key updates from HER2 positive metastatic breast cancer, as well as a few other subjects relevant in hormone and triple negative breast cancer, including capecitabine and topical diclofenac in 2023's Year in Review for OncoAlert. Thanks.
Hello, I'm Hope Rugo, a breast medical oncologist at the University of California, San Francisco's Comprehensive Cancer Center. On behalf of the OncoAlert Colloquium, it's a pleasure to present to you today the updates from 2023 for advanced triple-negative breast cancer. These are my disclosures. We're going to start with antibody drug conjugates. And overall, there weren't as many updates for triple negative breast cancer in the metastatic setting as there were for the other subsets of breast cancer. However, I think there was important data from a variety of trials that can help us treat our patients today, as well as give us a view to the future. There are a number of different antibody drug conjugates, the topic we'll start with, that are being tested or are approved for the treatment of metastatic and some early stage disease. We started with the HER2 ADC trastuzumab emtansine, which showed now survival data in the Catherine trial in patients with high-risk early stage HER2 positive breast cancer. But we've moved on to the new generation antibody drug conjugates. The difference in these antibody drug conjugates compared to their historical partners is both the potency of the antibody, although certainly for some, like T-DXd, the antibody is the same. The linker, where we now have cleavable linkers and can achieve for some of the ADCs a high drug to antibody ratio. However, we have very effective antibody drug conjugates that have a low drug to antibody ratio. So this is clearly not the only aspect that's important here. It may be that having a cleavable linker is relatively more important. And then the payload, which of course varies. Our initial ADCs used microtubule inhibitors like derivative of emtansine, and some of the earlier new generation ADCs like disitamab vedotin use an auristatin E. Both of these drugs cause neuropathy as well as some other toxicities, and this was dose limiting. ARX 788 is a new HER2 ADC that uses amberstatin, which is MMAF, and doesn't cause neuropathy, but does cause keratopathy, so eye toxicity, but is in clinical trials primarily in HER2-positive breast cancer. What about the ones in the middle? So T-DXd and sacituzumab govitecan have both shown efficacy in patients with triple negative disease. For T-DXd, a small number of patients with HER2 low disease, and sacituzumab govitecan with patients who had heavily pretreated triple negative metastatic disease. Datopotamab deruxtecan is being studied in triple negative disease and has encouraging early data. And then a new TROP2 ADC, SKB264, will enter into phase 3 trials both in the metastatic and early stage setting in the near future. Patritumab deruxtecan is a HER3 ADC, again using the same payload as trastuzumab deruxtecan and Dato-DXd deruxtecan, a topoisomerase inhibitor. And this drug has very intriguing data in early phase trials and will be entering into additional phase 3 studies in the future, although exactly how remains to be determined. We're going to focus on these drugs in this pink box that have data in triple negative breast cancer, and we'll talk briefly about some of the drugs that have presented phase 1 data this last year. So let's start with Destiny Breast 04. We saw at ESMO 2023 the updated survival results of T-DXd in HER2 low metastatic breast cancer. As you recall, this trial randomized 557 patients to T-DXd or treatment of physician choice, in which 50% of patients received eribulin in a 2-to-1 ratio. Patients had received a median of 1 line of prior chemotherapy, and the primary endpoint of this trial was in hormone receptor positive disease progression-free survival. However, there was a planned exploratory analysis of patients with HER2 low triple negative disease that enrolled 58 patients in a 2-to-1 ratio. So 40 patients received T-DXd and 18 patients received treatment of physician choice. There is now a longer median follow-up with this additional analysis of 32 months compared to 18 months at the initial analysis. Now, you would expect now that in the triple negative cohort that 18 months probably was enough to give us data, but it's important to see that follow-up just in case to understand what differences might exist. So here's the exploratory analysis in the HR negative cohort. Now, looking at progression-free survival, the trial ended the blinded independent central review with the protocol specified primary analysis of PFS. So this is investigators. So the hazard ratios are quite different, as you can see here, although the differences are quite similar. So 2.9 months for treatment of physician choice, and now 6.3 months for TDXD with a longer and more detailed analysis, longer follow-up in all patients. They did a 12-month landmark analysis, and as you can see, there is really a marked difference in progression-free survival favoring TDXD at this landmark. And then in terms of overall survival, which of course doesn't matter about central review since it's a hard endpoint, the hazard ratio is 0.58, so it varies just a little from the initial analysis, going from 8.3 to 17.1 months, a dramatic difference in overall survival, even with this longer-term follow-up, representing about a 42% reduction in the risk of death. In subgroup analysis only the overall survival was provided for all patients, and you can see all of the little diamonds line up to the left of one, and the IHC status didn't matter. Again, 58 patients is not going to alter this analysis much, and included all of the patients, but I think it's still useful to look at. Adverse events, again, would favor the overall population of HR-positive disease, but I think it reflects well for all patients. The primary toxicity is nausea. Only a small percentage had high-grade nausea, and otherwise the most common toxicities seen were lower-grade fatigue, transaminase increase, and alopecia. Bone marrow suppression is uncommon with TDXD, as our listeners know, and that's a real plus in treating patients who've been heavily pretreated, particularly those with triple-negative disease. Interstitial lung disease has been a significant concern with TDXD. However, the percentage rate of ILD adjudicated by a central committee stayed the same with longer follow-up, which is really encouraging. Most ILD first events occur within the first year, a little under 90%. Overall, there was a 12% rate of ILD with TDXD, and there was one additional death for a mortality rate of 1.1%. But this patient of note had pre-existing interstitial lung disease, but could not be saved despite aggressive treatment. As you can see, looking at these numbers, almost all of the cases of ILD were grade 1 and grade 2, and we all know now to hold drug for grade 1 asymptomatic ground glass opacities, and we often treat with steroids to try and hasten the time to the ability to re-challenge. And then for grade 2, we permanently discontinue and treat with steroids. Cardiac toxicity was a minimal toxicity in this study. We actually looked at the patients who were retreated after occurrence of grade 1 ILD in DB04 and presented this data at ESMO Breast. And as you can see, the small number of patients who were retreated did very well, and few had recurrent ILD. You can see that the initial treatment duration is in dark blue, and then the blue-gray color is the treatment after the initial ILD, and it shows you the ILD duration as well. And I think what's important about this data is to show you that patients who recover from grade 1 ILD can be retreated with significant clinical benefit, and that's really important. And recurrent significant ILD does not appear to be a big issue. One patient had recurrent ILD. We'll present later this year data on a pooled analysis of re-challenge in patients who have grade 1 ILD, and there will be additional data from institutional analyses as well. What about nausea? That's the most common toxicity with TDXD. What do we know about nausea? So there were more patients with TDXD than treatment of physician choice who received antiemetic prophylaxis, which was not mandatory per study protocol, but was recommended. As you can see, there were a few more patients who dose reduced due to nausea and vomiting, but actually a similar rate of dose interruption, and only one patient discontinued for nausea and for vomiting, respectively. NCCN actually lists TDXD as highly emetogenic, really allowing us to use 3 classes of antiemetic premedication, which is what's recommended. And if you start with 3 classes of antiemetics, you can tailor down in the patients who don't have significant nausea. And then we use a lot of olanzapine as a treatment for patients who have delayed or persistent nausea after infusion. And that works very well too, because we have seen this delayed persistent nausea with TDXD that responds well to olanzapine and other rescue medications, and when it doesn't respond well enough, we actually find it responds to dose reduction. There was also data looking at treatment emergent adverse events based on age that we presented at ESMO Breast. And here you can see that if you look at patients who are under 65 versus those who are 65 or older, the rates of any grade 3 or greater drug-related adverse events were relatively similar. And that's really encouraging. If you looked at interstitial lung disease, of course, the numbers are much smaller, so you can't really compare these. But what you can see is that the drug-related treatment emergent adverse events associated with discontinuation were much higher in the patients 65 or older. And I think that that's really important to mention because the patients who are 65 or older, almost with all treatments, including CDK4/6 inhibitors, have greater rates of drug discontinuation due to adverse events. Another thing that I think it's important with the way we monitor patients is that you can see that the number of patients who had adjudicated ILD pneumonitis was greater in the patients who were 65 years or older. And this means that we should be monitoring these patients a little more closely and not waiting 12 weeks, for example, before getting our first non-contrast CT of lungs in order to look for ground glass opacities. And then we also know that renal insufficiency, which is more common in the older population, can increase the risk of ILD. These patients were, of course, not allowed to be enrolled on DB04, but are important in the real-world setting. If we look at the grade 3 or greater treatment emergent adverse events in terms of which ones actually were higher in patients who are 65 or older, it's a little bit hard to pick out exactly what was causing this other than interstitial lung disease. So that's really important and really important. There's no difference in nausea, which is important. No difference really in neutropenia and no difference really in bone marrow suppression. So I think that that's very encouraging in looking at this analysis. Now, what about moving the use of T-DXd into patients who have more basal-like triple-negative breast cancer or HER2-0 disease? The only data we really have was published in Nature Medicine this year and looked at a small number of patients, 40 patients who had HER2-0 disease. And you can see that these patients did have responses. If you look at the PRs, there were partial responses, but no complete responses. That's on the far right for a response rate of 30%. Now, if you go across from right to left, what you can see is that in the middle cohort, HER2 low, and in the left-hand cohort, HER2 positive, you're seeing a marked difference in response. So the HER2 status, HER2 low or HER2 positive, clearly correlates with response. So in our patients who have triple-negative disease that's HER2-0, the response rates are much lower than what we expect to see from T-DXd in patients whose tumors express even a little bit of HER2 by immunohistochemistry. The same is true for progression-free survival. So here you can look at cohort 1, HER2 positive, cohort 2, HER2 low, and cohort 3, who are HER2-0. And you can see that the PFS clearly trends down as patients have less expression of HER2, even by our relatively imperfect measure of immunohistochemistry, as many have discussed. Still, the median PFS in cohort 3 was 4.2 months, but I was very interested to know what this was in the hormone receptor negative HER2-0 population, that true basal-like triple-negative population. And the PFS was only 2.1 months, very similar to what we see with capecitabine, which we think doesn't work in that population. And the median overall survival was 10.3 months. So looking at this actually suggests that potentially T-DXd doesn't work well for true triple-negative HER2-0 disease. But for HER2 low disease, we're seeing progression-free survivals of the 6.7 months, including both triple-negative and hormone receptor positive disease. So this is an area of great interest. So in the hormone receptor positive cohort, Destiny Breast 06 will look at in 150 patients at tumors that are HER2 ultra low, so not 0, but not 1+ in between. But this won't really help us much in our analysis of triple-negative disease, and really datopotamab deruxtecan, called Dato-DXd, is really the agent that's moving forward in triple-negative disease rather than T-DXd. Sacituzumab govitecan was the first ADC to be approved for triple-negative breast cancer, regardless of HER2 expression, based on data from the ASCENT phase 3 trial in patients who had had a median of 4 lines of prior chemotherapy, including early stage, so about 3 lines in the metastatic setting. Both progression-free and overall survival were significantly improved, and that difference occurred very early for overall survival and after the first scan for progression-free survival. So this really changed our entire treatment approach for patients with metastatic triple-negative breast cancer who have a very poor prognosis after diagnosis of metastatic disease. We learned that TROP2 is expressed in all subtypes of breast cancer and expressed at very high levels. So TROP2 expression has not been associated as yet with response to sacituzumab govitecan, looking at high versus low expression. Sacituzumab primarily causes neutropenia. It's the most common grade 3 or greater treatment-related adverse event at 51 versus 33%. And then diarrhea is the next most common with 10% rate of grade 3 diarrhea, although that dropped to 9% in the Tropics trial in hormone receptor positive disease, presumably because we've learned better how to manage the drug. Despite the fact that there was more neutropenia, the incidence of febrile neutropenia was only minimally increased. Twice as many patients received growth factors who received sacituzumab versus treatment of physician choice, which again, in 50% of patients was eribulin. So what about the relationship of diarrhea and neutropenia with outcomes in patients with metastatic triple-negative breast cancer treated with sacituzumab? This is the post-hoc ASCENT analysis presented at ESMO Breast this last year, and actually very interesting. So if you look at PFS in patients who had diarrhea and OS in patients who had diarrhea, you can see that patients still did much better than the PFS and OS was increased in patients who had an adverse event, which is quite intriguing. The same was not true of neutropenia, which probably has much more to do with the amount of prior treatment, because as we've been moving the drug earlier in the line of treatment after its approval, we've seen much less neutropenia up front. It takes quite a while to get enough neutropenia to require growth factor use. Now, then we did an adjustment for age, race, and body mass index, which is actually quite interesting and probably takes into account the possibility that there might be pharmacogenomics that would play a role in this toxicity. And what you can see is that once you've adjusted, that there's absolutely no difference in outcome based on adverse events. This is quite intriguing, and it relates to UGT1A1 polymorphisms. Here you can see that only about 10% of patients have the STAR28 homozygous phenotype for UGT1A1, but those patients, when you look at ASCENT and TROPiCS-02 and HR-positive disease, appear to have more diarrhea and neutropenia relative to patients who are metabolizing the drug normally. So that encourages us, and we published this data for Tropics in Lancet 2023, and then the data from ASCENT has been presented earlier. It encourages us to dose reduce early in patients who have diarrhea because we know we're going to maintain efficacy because these patients will have significant drug exposure regardless of dose reduction. So that's actually quite encouraging. There are a number of trials looking at sacituzumab govitecan in triple-negative disease. We have the first-line trials, ASCENT-03 and 04, really divided by whether or not there's PD-L1 expression and combining with pembrolizumab or using as a single agent compared to treatment of physician choice, again, first line. There's also sacituzumab govitecan being tested in patients who have PD-L1 negative disease in an investigator-initiated trial, multi-center out of Dana-Farber, with or without pembrolizumab in both TNBC and HR-positive disease. And then there are two post-neoadjuvant trials, Saskia, that includes both HR-positive and triple-negative disease, and Optimize RD or ASCENT-05, a large randomized trial which is now ongoing, randomizing patients to sacituzumab govitecan and pembro versus pembro and capecitabine per physician choice in patients with residual disease after neoadjuvant chemotherapy. So datopotamab deruxtecan is the next kid on the block in terms of TROP2 ADCs. It carries that same toxin, deruxtecan, a topoisomerase 1 inhibitor. It has a drug-to-antibody ratio of 4, but it has a high potency payload, as we know, a tumor-selective cleavable linker, and an antibody that's quite potent in terms of its ability to target the TROP2 receptor. And, there's this idea that these ADCs have a bystander tumor effect. So datopotamab, of course, presented data from TROPION-Breast01 in HR-positive disease and is enrolling patients, as I'll show you in a moment, in triple-negative disease. But this data was presented at ESMO 2023 from the Begonia trial, looking at Dato-DXd plus durvalumab as first-line treatment in triple-negative breast cancer. 62 patients were enrolled with a median follow-up of about 12 months. There are durable responses and quite a high level of responses. 79% was quite high. And you can see that waterfall plot is very impressive. And then the spaghetti plot shows that most of the patients had very, very durable responses. So quite intriguing for this agent. The most common toxicity for Dato-DXd is stomatitis, although this appears to be reduced in terms of grade from the 11% range based on the TROPION-Breast01 trial, with encouragement to use a steroid mouthwash as prevention. ILD pneumonitis was seen in 5%, so it's clearly a potential toxicity, but there was all grade 1 and 2, and it was impossible to differentiate the risk from Dato-DXd versus durvalumab. Overall, Dato-DXd appears to cause a very low rate of ILD. There are a number of ongoing trials, as I mentioned, TROPION-Breast02 in the first-line setting, looking at Dato-DXd versus treatment of physician choice for metastatic triple-negative breast cancer, TROPION-Breast03, which is looking at patients who have residual disease after neoadjuvant therapy with datopotamab and durvalumab versus Dato alone for 8 cycles, and standard of care with Pembro Cape as needed. There's a neoadjuvant trial for triple-negative breast cancer that's just started, and then TROPION-Breast05 as well listed here that will enroll 625 patients who are treated and with Dato, Durva, investigator choice chemo plus Pembro versus Dato-DXd in the first-line metastatic triple-negative setting. So what about using sequential antibody drug conjugates? We saw this data at ASCO this year showing that in a small cohort of patients that the first ADC seems to work better than the second. But as you can see, looking at those pink lines, there are some patients for whom the second ADC works better than the first one, which is really intriguing, and we don't really understand that well. There were just 20 patients with triple-negative breast cancer included here, but additional data was presented at San Antonio, looking again both at HER2 low or triple-negative hormone receptor positive disease. So here in triple-negative disease, HER2 low disease, they looked at patients who received sacituzumab followed by TDXD or TDXD followed by sacituzumab. And here you can see the median progression-free survival 1 was longer than 2. And it's actually quite interesting. Most of the trials now, all these retrospective institutional analyses have shown that PFS1 is in the 4.9-month range and PFS2 around 2.5 months. So very, very similar, which is interesting. In this particular analysis, in the patients who had largely hormone receptor negative disease, it looked like sacituzumab followed by TDXD resulted in better outcome than TDXD followed by sacituzumab govitecan, but obviously this data would need to be confirmed in the future. And then my colleague Laura Hubbard did a multi-institutional review, a retrospective review, looking at patients who had received sequential SASI versus TDXD in either order. And this is the data in hormone receptor negative disease, showing again that the first ADC generally works better than the second. And because there's really level 1 data for triple negative disease with sacituzumab, and there's just the exploratory analysis with TDXD, and they have to be HER2 low, more patients were available who'd received SASI first. And what you can see is that mostly PFS1 is better than PFS2, but again, there's a small number of patients where PFS2 was longer when patients received SASI first and TDXD second. So clearly we need to understand this better because it's very, very hard to know. There were only 3 patients who received TDXD first for a triple negative disease, presumably HER2 low. And in those patients, PFS1 was longer than PFS2. And then another study was fascinating by Ocho Grosso, and this study looked at the differences in cross resistance to later ADC based on the ADC to ADC characteristics. So looked at change in antibody, change in target or not. And you can see that, it's really hard. The numbers are small to really understand whether or not there's any differences here in terms of the time to progression based on whether you change something or not. But 3 patients in one group, same antibody target, same payload, really hard to know. If you change the payload, 8 out of 14, so 57% responded, versus change in the antibody with the same payload, where just 30% responded. So I think we're going to need much more data with larger numbers in the future to understand this. We also would like to know whether or not changing for, looking at mutations might help us, for example. And this is, again, additional data from that same presentation where there were variations in a variation in TOP1 in one patient, but that patient actually responded to an anti-TROP2 antibody with a topo-1 isomerase inhibitor payload for a long period of time. So that clearly looking at variations in the target of the payload may not help us much in understanding the effectiveness, because these TROP2 antibodies all carried a TOP1 inhibitor payload, but they still resulted in very good efficacy that was prolonged almost a year or longer, despite the fact that these patients had mutations in TOP1 or TOP2/3. So we need more work, and more work is coming. So this trial, which is called TRADE-DXd, will look at sequencing T-DXd and Dato-DXd, and then Laura Hubbard is working on a registry study, again, through our consortium, looking at T-DXd and sacituzumab. So more data in the future. What about patritumab deruxtecan? This is a phase 2 study of HER3-DXd in 60 patients. Triple-negative patients had 1 to 3 prior chemotherapy lines. And if you look at the patients in the curve, you can see that the responses were excellent in this group of patients with the response rates of 35% and no relationship to HER3 expression. The duration of response was quite good, and the drug is well tolerated. Some thrombocytopenia, although doesn't seem to be dose limiting, and primarily nausea, diarrhea, and fatigue. So if you look at that overall response there for the 19 patients with triple-negative disease, it was 21%. Clearly, we need more data on this agent, and will be interesting to see what this shows us in the future. I mentioned SKB264 for metastatic triple-negative disease. This is a novel TROP2 ADC. Again, it carries a topoisomerase inhibitor, and shown in this cartoon, really. The topo-1 inhibitor is novel belotecan derivative, and then it has a new linker, which is supposed to also result in a bystander effect. This linker is also able to release the payload in an acidic environment, relying on hydrolysis. So you can see that the duration of response was quite good in these patients as well. Overall response of 42%, and in those with high TROP2 expression, 53%. And then looking at the plot of overall survival, it was also quite encouraging. And I show this really to show you the rates of toxicity. And again, interestingly, although sacituzumab doesn't cause it, this TROP2 ADC causes stomatitis with a grade 3 rate of about 6.8%. So again, it will be important to look at prevention in order to see if we can control this toxicity, which is quite bothersome to patients. About a 39% rate of all grade thrombocytopenia. So again, and then lastly, this drug, unlike Dato-DXd, but more like sacituzumab, causes white blood cell count decrease with neutropenia of all grade at 67.8%, and a quarter of patients having grade 3 or greater neutropenia. So as I mentioned, this drug is entering into phase 3 trials in the first-line metastatic triple-negative setting and in the post-neoadjuvant setting, so it'll be interesting to see what happens. This is a very interesting EGFR HER2 bispecific antibody drug conjugate, and this is being studied in a number of different tumor types. This was a dose escalation expansion trial where they saw a reasonable number of responses. I would say that this data is quite early, and the overall response rate in 35 patients with triple-negative disease was 31%. As you can see, it has HER3 and EGFR in the targeting area, and the DAR is 8 here. So that's actually quite encouraging. Here's additional results of response, just showing you the waterfall plot. They see some neutropenia, and the benefit was seen regardless of EGFR expression or tumor type. B7H4 ADC is quite fascinating. This was studied in patients with advanced solid tumors. B7H4 is actually an important molecule in terms of the immune system, and it's an immune effector target, and it conjugates the humanized anti-B7H4 to a topo-1 inhibitor with this cleavable linker. And as you can see in a dose escalation study, they did see some neutropenia as their primary toxicity and some nausea, but overall seemed to be quite tolerable. And then in triple-negative breast cancer, saw a very reasonable response rate of 50%, even at quite low doses. So this drug will also move forward in additional trials in breast cancer. So now let's just close and talk about an update on immunotherapy. KEYNOTE-355, we all know, improved both progression-free and overall survival in patients with PD-L1 positive metastatic triple-negative breast cancer combined with a taxane or gem-carbo in patients who were at least 6 months from their treatment with curative intent. This represents about 38% of patients with triple-negative breast cancer. We were interested in patients who were treated with pembrolizumab on KEYNOTE-355 who discontinued chemotherapy before pembro and used pembro as maintenance. In these patients, overall, the median progression-free survival was very good, as was the overall survival, suggesting that you could actually stop chemotherapy in responding patients. And some, it certainly suggested here in the small number of patients who discontinued, who had a CPS of 1 or greater, that these patients just did much better than patients who did not respond. So pembrolizumab is likely to be doing something to prolong the response here. And then we also looked at patients who had immune-related adverse events, another important area to think about. In these patients, we also seemed to show that the overall survival was longer than what we would have expected. If you look down to the bottom where patients had a CPS of 10 or greater, the median overall survival was 35.6 months versus 22.8 for all. And in all categories, CPS of 1 or greater or 10 or greater, you can see that the median overall survival in patients with immune-mediated adverse events was longer. So this is quite intriguing and needs to be evaluated in the early stage setting as well, of course. So you definitely can stop chemo in responding patients and continue pembro alone, so that's quite encouraging. And the immune-mediated adverse event association with outcome needs to be further evaluated. We presented data at San Antonio this year looking at pembro olaparib after induction of pembro chemo for patients in the first-line setting who'd received a gemcitabine and carboplatin with pembrolizumab, regardless of their CPS score, and had responding disease. And as you can see, one group of patients, it was randomized 2-to-1, received olaparib pembro, and the other group of patients received continued gem carbo and pembrolizumab. The median follow-up was about 17 months in this group. And what we showed was that there was absolutely no difference in progression-free survival in patients who received the maintenance pembro olaparib versus continuing pembro and chemo. But then we looked at differences in patients who had BRCA mutations versus BRCA wild type. And what we saw was quite interesting, which suggested that patients who had BRCA mutations actually seemed to have benefited more from receiving the olaparib pembro versus pembro chemo and that's in the lower right-hand curve there, where it was not reached versus 23.4 months for progression-free survival. Again, these are very small numbers, but it's quite encouraging. And the tumor-mutated, BRCA-mutated population for progression-free survival is on the left-hand side, and you can see the 12-month PFS does seem to be better in patients who receive pembro and olaparib, but this is just hypothesis-generating data, and the PD-L1 status didn't matter. In terms of safety, there was no increase in toxicity by adding pembro to the chemotherapy, as we know, but also the pembro and olaparib was much better tolerated than the pembro and continued chemotherapy. So what we believe from this is that what this shows you is that you can actually, again, drop chemo and continue pembro alone. We don't know what the benefit of pembro plus olaparib is, and I hope that we're able to look at methylation as well as the BRCA mutation status to better understand this effect in the overall population. The adverse event profile is much better when you drop the chemotherapy, and I think that this encourages us to really stop chemotherapy in responding patients and continue pembrolizumab alone in our patients who have PD-L1 positive disease. There is interesting data from olaparib with or without durvalumab as maintenance therapy for metastatic triple-negative breast cancer presented at San Antonio, but they did an additional analysis of these patients looking at methylation at ESMO Breast this year, which I think was quite intriguing. And there were patients who did not have a BRCA mutation who stayed on the maintenance of olaparib and durvalumab for a long time. And for these patients, we believe that methylation may play a role. And this is from OncoReveal studies presented at ESMO Breast, where it did appear that RAD51C high patients seem to have the longest duration of maintenance therapy. So I hope we're able to look at that in the KeyLink trial, which might help us and identify an additional group of patients who could benefit from this strategy in the future. So I've told you about antibody drug conjugates, a better understanding of immunotherapy, our next steps in optimizing treatment in earlier lines of chemotherapy for antibody drug conjugates, and then combinations with immunotherapy for enhancing efficacy and new antibody drug conjugates. I hope that you found this useful. Certainly, we're still using pembrolizumab and chemotherapy as our first approach outside of studies with chemotherapy in patients who have PD-L1 positive metastatic triple-negative disease. And our options for patients with PD-L1 negative disease, of course, are driven by BRCA mutation status. And then we use sequential antibody drug conjugates now, as well as chemotherapy and checkpoint inhibitors in patients with high tumor mutational burden or MSI high tumors. So certainly we're looking for this next generation of trials to further improve outcomes for patients with this disease. Thank you so much for your attention, and thanks for OncoAlert for hosting this important series of talks.
Hello, this is Dr. Maryam Lustberg speaking on early stage triple-negative breast cancer. Here's the agenda. I'll give an overview of triple-negative breast cancer, starting out with the very smallest tumors that are T1A and T1B, then go on to stage 2 and stage 3 triple-negative breast cancer and their preoperative management. Then I'll discuss adjuvant therapy consideration and wrap up with future directions. Starting out with an overview of triple-negative breast cancer. As many of you know, this is considered one of our most aggressive types of breast cancer with higher likelihood of recurrence, typically peaking within the first 3 years after treatment. The mean time to distant recurrence is much earlier than ER-positive tumors. And tends to peak at around 3 years. Most deaths, unfortunately, occur in the first 3 to 5 years. It's important to note that triple-negative breast cancer is not one disease type, and there's multiple additional subtypes of triple-negative, with basal cell-like being the most common and thought to be the most aggressive subtype. There's also immunomodulatory, androgen receptor, and mesenchymal subtypes. As you can see in the pie diagram on the right, there are multiple different pathways that could potentially be exploited for additional therapeutic benefit, and these are listed here. I want to draw your attention to the immune-enriched subtype of triple-negative breast cancer, which tend to have tumor-infiltrating lymphocytes. And these high TILs have been associated with both better prognosis as well as better response to neoadjuvant chemotherapy. Higher TILs are found in both HER2-positive and triple-negative breast cancers, and as you can see here, many, up to a third of triple-negative breast cancers can have high TILs, and these have been associated with higher complete pathologic response rates. This year, we had correlative studies on a non-anthracycline preoperative regimen that included pembro and platinum therapy. And as you can see here, triple-negative tumors that had high TILs counts, actually 74% of them were able to achieve a complete pathologic response, and this joins a body of work that has shown that high TILs tend to be associated with better response to chemotherapy. The question that remains is whether tumors that are high in TILs could perhaps receive much less intensive chemotherapy and still have better outcomes. Do you want to highlight the discussion of HER2 low, defined as immunohistochemical staining of 1+ and 2+ with negative FISH? Over a third of triple negative breast tumors actually can be classified as HER2 low. As you have heard in the metastatic triple negative lectures with an OncoAlert, within the past 2 years, we've had the opportunity to treat the metastatic triple negative breast tumors with antibody drug conjugate therapy targeting the HER2 pathway. We currently do not have solid data for use of antibody drug conjugate therapy in the preoperative setting for these HER2 low triple negative breast tumors, but this is a pathway that is continuing to be looked at. In addition to HER2 low, there was additional discussion of the prognosis of ER low tumors, defined as those with 1 to 10% positivity. And in this meta-analysis from Sweden, this compilation of studies with that included neoadjuvant chemotherapy response in ER low breast cancers really showed that ER low breast cancers tend to behave most similarly to triple negative breast cancers, both in terms of prognosis as well as response to neoadjuvant chemotherapy. So I think we have begun to increasingly recognize that ER low tumors are really should benefit from treatment regimens very similar to triple negative breast cancers. So moving on to a discussion of very small triple negative tumors, defined here as less than 1 centimeter, and we have older series showing that in this particular series from MD Anderson, which included over 1,000 breast cancers diagnosed between 1990 and 2002, the triple negative breast cancers tended to have a worse prognosis. As you can see here, the 5-year disease-free intervals range from 75 to 88%, and this, in addition, younger age and HER2 positivity were also associated with worse outcomes. However, this is an old series with more limited triple negative breast cancers. Most recently, in the last year, we have data from the SEER database looking at stage 1A triple negative breast cancers, and this included a study population of over 8,000 patients, which showed that in this more modern series, very small tumors with microscopic or T1A triple negative breast cancer really did not additionally benefit from the use of chemotherapy. As you can see here, there was really no difference between the two groups. Similarly, in the T1B group, there was no difference between the two groups, between receipt of chemotherapy or not. However, we begin to see a small difference of about 3% in T1C tumors. These data further highlight the growing recognition that very small triple negative tumors may not benefit from additional chemotherapy, and that we can confidently say that T1A tumors do not need additional adjuvant therapy. T1B tumors can be a discussion depending on patient's age and other characteristics, and then from T1C forward, these tumors do need some type of systemic therapy to improve disease outcomes. Moving on to higher stage, higher risk triple negative breast cancers, which we treat preoperatively. Typically, these are defined as tumors that are greater than 2 centimeters, but may include even some selected T1C tumors. So one question that was discussed in San Antonio this year was the role of optimal immunochemotherapy agents in the perioperative setting. The Alexander and Passion 030 phase 3 trial was shown as the interim analysis, looking at the addition of atezo to adjuvant chemotherapy for stage 2 and stage 3 negative triple negative breast cancer. And as you can see, this was a higher risk population with at least 50% of them being node positive. And this was a non-carboplatin containing regimen as opposed to the Keynote 522 regimen with Pembro. But it was a classical third generation chemo with AC and Taxol plus or minus immunotherapy. As was previously reported, the PCR rates in Passion 130 did show that the addition of immunotherapy did improve PCR rates in all groups, both PDL positive and PDL negative, similar to the Keynote 522 data. However, the interim analysis for the primary efficacy endpoint of invasive disease-free survival showed that there was no difference between the addition of atezo to traditional third generation chemotherapy. There's no difference in overall survival, and this led to the conclusion that atezo in the preoperative setting should not be used. There was an updated analysis of Keynote 522 in this year's San Antonio, further confirming this regimen as our current standard of care. As you can see here, this is a very intensive regimen that includes anthracycline, platinum, as well as taxanes, with the addition of pembrolizumab in the preoperative setting as well as in the adjuvant setting. The updated results from San Antonio confirm that all groups continue to benefit from the addition of pembrolizumab. As you can see here, there is greater curve separation in patients who did not achieve a PCR in both stage 2 and stage 3, but we're beginning to see even a separation in patients who did achieve a PCR in both stage 2 and stage 3, with patients who did receive pembro doing slightly better than those without immunotherapy. In terms of distant recurrence rates, you can see that there were small rates of CNS disease that was noted, with the majority of distant recurrences being in the body, and as expected, higher percentage of distant recurrences were seen in patients who did not achieve a PCR, although even patients with PCR had small rates of recurrence, especially if they had not received immunotherapy. So the study conclusions were that essentially it appears that the reductions in event-free survival events appear to be significant in the pembro group, regardless of PCR outcome, and that the benefit with pembro was generally consistent in the key subgroups based on both stage and nodal status. Additional biomarker data analyses are upcoming in 2024, and follow-up for overall survival is ongoing. The questions that still remain from Keynote 522 is, are there a subset of patients who can get less intensive therapy and still do well? And are there additional strategies that we can utilize for patients who are at high risk? And these continue to be the subject of ongoing investigation. To recap, the immunotherapy-based regimens that previously studied and reported in the preoperative high-risk triple-negative breast population. I will share this table for your reference. showing the type of backbone chemotherapy that was used, when carboplatin was utilized versus not, and when adjuvant immunotherapy was used. As you can see here, Japar Nuevo study did not extend the immunotherapy beyond the preoperative period. And so this table summarizes the range of agents that have been used and what the PCR outcomes as well as event-free survival events were. The questions remain in terms of how we can best de-escalate or right-size triple-negative preoperative regimens, whether it be with biologic targeted therapy that are chemotherapy-free, anthracycline-free regimens, as well as completely chemo-free regimens. I will cover these three subjects. So previously, we had seen data with neoadjuvant talazoparib for 6 months in the preoperative period, showing that particularly in the triple-negative breast cancer population, there were impressive PCR rates noted on completely chemotherapy-free regimen. This was certainly thought-provoking about using a completely biological targeted therapy for these high-risk tumors. It's notable that over 2/3 of these tumors were stage 1 and 2, and 79% were BRCA1. These data were part of the foundation for the currently ongoing TBCRC056 study that is a non-chemo regimen for patients with germline BRCA1, 2, or PALB2 alterations, looking at the combination of PARP inhibitor plus immunotherapy in various combinations, as you can see here, for tumors that are 1 centimeter or larger. This trial is ongoing and results are not currently available. Moving on to anthracycline-free regimens, the NeoStop regimen was previously reported, showing that docetaxel plus carboplatin had a similar rate of PCR to paclitaxel, carboplatin, and a C third-generation regimen. And as you can see here, high rates of PCR and similarity in both groups were reported in patients with stage 1 to 3 triple-negative breast cancer tumors, and the non-anthracycline-containing regimens were better tolerated and had higher therapy completion rates. There have been other non-anthracycline based regimens. This one is the NeoTrip study, which was utilizing a Tesla-based pre-op therapy with taxane and carbo. And as you can see, PCR rate after treatment with Atezo did not reach statistical significance compared to no Atezo, but close to nearly half the patients were able to achieve a PCR without the addition of anthracyclines. Then most recently, the NeoPAC study was reported, and this is a taxane carbo plus pembro regimen that was a phase 2 trial, and as you can see, patients had high PCR rates and 3-year disease-free survival events, especially if patient had a PCR, were excellent. And this is the foundation for the Scarlet study, which is currently going, taking patients with triple negative breast cancer that are T2 or higher and randomizing them to the traditional Keynote 522 regimen versus an anthracycline regimen that contains carboplatin, taxane, or pembrolizumab. And those who achieve a PCR can go on to receive adjuvant pembrolizumab, and those with residual disease have the option of additional chemotherapy per physician choice. And the question also remains, can we give no chemotherapy for selected triple negative breast tumors? And currently we have a small series of data showing that in stage 1, triple negative tumors that have high TILs tend to have excellent disease-free survival, even without chemotherapy. So definitely thought-provoking. In terms of postoperative adjuvant therapy recommendation, our current state of care is Keynote 522 type regimen with anthracycline, carboplatin, and taxane plus pembrolizumab in the preoperative setting. And then for patients who do have residual disease, we're using capecitabine based on CREATE-X, unless patients are in a clinical trial. Typically, the capecitabine is combined with pembrolizumab. And then for patients who do have residual disease but have germline BRCA alterations, based on Olympia data, we can use olaparib adjuvantly in combination with pembrolizumab. So, but what can we do better, and what are some upcoming trials in this area? The optimized PCR study is asking the question whether adjuvant pembrolizumab is actually needed in patients who have achieved a complete pathologic response. And this trial is ongoing, and it will be an important strategy for answering this question. Additional studies are looking at how can we optimize outcomes in patients with residual disease, and this includes the incorporation of antibody-drug conjugates. This is the SASHIA study, which randomizes patients to sacituzumab versus physician's choice. And this trial is ongoing with one interim analysis already reported. The Torpion-03 study uses another antibody drug conjugate, Dato-DXd, and patients with residual disease after triple negative breast cancer preoperative treatment are randomized to Dato-DXd versus investigator's choice. There's also an arm that combines Dato-DXd with durvalumab. An additional residual disease trial is the ASCENT-05 optimized RD trial, which takes patients with residual disease and randomizes them to sacituzumab plus pembro versus physician's choice plus pembro. As we talk about minimal residual disease, there is a large body of work suggesting that detection of circulating tumor DNA at the end of preoperative chemotherapy can be highly prognostic, with patients who have ctDNA positivity tending to have worse outcomes. Additional investigations are needed, whether acting on these ctDNA positive findings with more novel therapies actually can change the course of disease. Moving on to future directions in early stage triple negative breast cancer, I think we continue to ask the question of how much immunotherapy with checkpoint inhibitors is actually needed. As I previously stated, JEPAR Nuevo study showed long-term outcomes comparable to Keynote 522 without adjuvant immunotherapy use. And so with the optimized PCR study, we hope to be able to answer the question of whether adjuvant immunotherapy is really needed in those population. The Impassion 030 did not show a benefit to adjuvant atezo, and we're awaiting results from SWOG 1418, which is the use of adjuvant immunotherapy in triple-negative breast cancer after preoperative chemotherapy. We continue to ask the question of who needs anthracyclines, and the SCARLET study will be helpful for that. And we continue to investigate better biomarkers of benefit and toxicity, including assessment of minimal residual disease. So we look forward to ongoing trials in this area, and I thank you for your attention.
Dear colleagues, it's a great honor and pleasure for me to be part of this OncoAlert Colloquium 2023. My name is Matteo Lambertini. I'm a medical oncologist and associate professor in medical oncology at the University of Genova San Martino Hospital in Genova, Italy. And I'm going to address today the topic of hormone receptor-positive early breast cancer. Here my disclosure, and here the outline of my presentation, where I'm going to address the news in 2023 related to the updates on systemic therapy as well as on survivorship. As introduction, just a couple of slides on important guidelines that have been published in 2023 or at the end of 2022. And I will start by acknowledging the ESMO guidelines on early breast cancer that has been published at the end of 2023, where we have here in the box the main systemic treatment options that are being recommended in patients with early breast cancer. As we know, endocrine therapy being the cornerstone of treatment in this disease, adjuvant biphosphonate has now level 1 of evidence and grade A of recommendation in the setting of postmenopausal women receiving endocrine therapy, and for postmenopausal definition, and the postmenopausal definition includes also premenopausal women receiving ovarian function suppression, and then the use of other systemic treatment option, chemotherapy, targeted treatment option for patients at higher risk of disease recurrence. The second guidelines are the ASCO guidelines on the use of biomarker in the field of to make adjuvant endocrine chemotherapy choices in early breast cancer. And here is a cartoon of the use of genomic testing that are helpful in those patients in the gray zone for chemotherapy use in both premenopausal and postmenopausal patients, reminding that for premenopausal women, the evidence is for those patients with no negative disease, not really in the not positive setting, while for postmenopausal patients, there is evidence to use genomic testing to make chemotherapy choices in patients with both non-negative as well as with N1 disease, so 1 to 3 positive nodes. In terms of update on systemic therapy, we'll start with the EBCTCG meta-analysis that have looked into the optimal chemotherapy backbone in the adjuvant-neoadjuvant setting in breast cancer patients overall, including those with hormone receptor-positive disease. Main message is that anthracycline taxane-based use concurrently, like the TAC regimen, as compared to TC, is superior, improves the outcomes. However, if we look at the comparison of sequential anthracycline taxane-based option, which is our standard of care right now, as compared to TC, there is not really a major difference there. So personally, the use of anthracycline, including for patients with hormone receptor-positive breast cancer, I tend to use them in patients with high risk of disease recurrence. When there is indication for chemotherapy, but the risk of recurrence is lower, the TC treatment option, to me, should be considered as the preferred chemotherapy option in this setting. For endocrine therapy, we had news for premenopausal patients, particularly with the use of OFS plus tamoxifen and OFS plus AI. I will start with the updates of the SOFT trial and the ASTRA trial that have looked into the benefit of adding ovarian function suppression on the top of tamoxifen in premenopausal patients with hormone receptor-positive disease. The two studies had a slightly different design. In the SOFT trial, the treatment was 5 years, so randomization of tamoxifen 5 years versus tamoxifen plus OFS for 5 years, which was the primary comparison, and then we had a third arm of OFS plus exemestane. Half of the patients received chemotherapy, half did not. Those patients that received chemotherapy had to resume ovarian function within 8 months following chemotherapy completion to be eligible to the study. In the ASTA trial, all patients received prior chemotherapy, and the randomization, and to be eligible, they had to resume ovarian function within 2 years following chemotherapy completion, and the randomization was between 5 years of tamoxifen with or without 2 years of ovarian function suppression. Here, the updated results from the study started with the soft trial at a median follow-up of 12 years. Main message is that the inclusion of ovarian function suppression improves also overall survival for patients at higher risk of disease recurrence, like patients receiving prior chemotherapy. Around 5% absolute benefit at 12 years in overall survival has a ratio of 0.75, while there is no difference in overall survival for patients at lower risk of disease recurrence, those patients that did not receive chemotherapy. Very, very good overall survival at 12 years, no difference between treatment arms, suggesting that tamoxifen alone is still standard of care in low-risk patients. The Astra trial provided updated results at 8.9 years median follow-up. The study met its primary endpoint, showing a significant improvement in disease-free survival with more than 5% absolute difference at 8 years, and also an improvement in all the other survival endpoints, with the exception of overall survival, where there was a trend for better overall survival. It was not statistically significant. We don't know if this is the shorter duration of OFS, the shorter follow-up, but I believe that this trial provides evidence to support the use of 2 years OFS, particularly for those patients that do not tolerate the treatment and cannot reach the 5-year duration as per the soft trial design. For the use of aromatase inhibitor together with ovarian function suppression, we had the publication of the 13-year follow-up data from the joint analysis of soft and text that compare 5 years of treatment with OFS plus tamoxifen versus OFS plus an aromatase inhibitor being exemested in these two trials. There was a significant improvement in disease-free survival, 4.6% absolute improvement at 12 years. However, this improvement did not translate into an overall survival benefit. Overall, there was no difference between these two treatment options. By looking at the different subgroups, the main message is that in patients with the HER2 negative, hormone receptor positive disease that receive prior chemotherapy, there is a tendency for better overall survival with this combination, around 3% absolute gain at 12 years that was not statistically significant. So to me, this option should be considered as the preferred option for patients with very high risk of disease recurrence, or the higher the risk of recurrence, the more likely I consider this option as the preferred treatment option. At the ASCO conference, we had the presentation of a large ABCTCG meta-analysis on the use of ovarian function suppression in premenopausal women with hormone receptor positive breast cancer. Main message from this meta-analysis is that this data further reinforce the importance of considering ovarian function suppression in patients receiving chemotherapy, meaning patients at higher risk of disease recurrence, and particularly the higher the risk, very young patient, node positive disease, the larger the expected benefit with the inclusion of ovarian function suppression as part of the adjuvant endocrine therapy. In 2023, we have definitely had important data to support the use of adjuvant CDK4/6 inhibitor on the top of endocrine therapy in patients with high risk of disease recurrence. We have now 4 different randomized trials that have looked into this agent, 2 of them with palbociclib being negative studies, 2 of them with abemaciclib monarchy, ribociclib NATALEE being positive and providing evidence also in 2023. I will start with the monarchy, which is so far the only adjuvant CDK4/6 inhibitor approved in this setting, which is abemaciclib. This has been studied in a trial that included more than 5,000 patients with a quite high risk of disease recurrence. Patient had to have an N2 entry disease, so 4 or more than 4 positive nodes, or those patients with N1, so 1 to 3 positive nodes, they had to have at least 1 additional aggressive feature, grade tumor or tumor larger, of 5 centimeters or larger. Small cohort of patients, less than 10%, in which this 1 to 3 positive node cohort did not require grade 3 or large tumor, but could be included with a high Ki-67. 60% of patients had the N2 entry disease, and the randomization was between endocrine therapy plus 2 years of adjuvant abemaciclib. At the ESMO conference, the author provided the almost 5 years median follow-up data that has been published in the Journal of Clinical Oncology a few days ago. The results are quite reassuring because we see a constant improvement in outcomes over time, a sort of carryover effect. And now at 5 years, we see a 7.6% absolute difference in disease-free survival with a hazard ratio of 0.68 and similar findings also in distal relapse-free survival. Based on this follow-up, overall survival, there is no difference in overall survival, but I will definitely consider this outcome still immature with this follow-up. But we start seeing some differences in the number of patients living with metastatic disease, being a larger number in the endocrine therapy alone arm. The second trial that provided data first at ASCO and then updated in San Antonio 2023 is the NATALY trial with the use of adjuvant ribociclib. Main differences as compared to the prior study are first the duration of the CDK4/6 inhibitor, 3 years versus 2 years of the monarchy study. Second is that the endocrine therapy backbone could be only an aromatase inhibitor-based treatment, not tamoxifen, as was used for some patients in the monarchy trial. And third, and probably the most important difference, is that in this study, there was also a cohort of patients with lower risk of this recurrence as compared to the monarchy trial, also patients with stage 2 disease, and also some patients with node negative and some other aggressive features like high genomic testing or high Ki67. And if we look at the number of patients with N2, N3 disease, more than 60% in the monarchy trial, it was less than 20% in the NATALY trial, with almost 30% of patients with node-negative disease. The results presented at San Antonio were updated at a median follow-up of 33 months. At this follow-up, there is still around 20% of patients receiving ribociclib as part of the study, with slightly more than 40% of patients that completed the 3 years treatment duration or follow-up duration. In terms of disease-free survival, despite the short follow-up, we start seeing the separation of the curve with around 3% absolute improvement in disease-free survival and a 2.5% improvement in distant disease-free survival. As expected, if we look at the efficacy of this treatment option according to stage, we see a larger benefit in patients with a higher risk of this recurrence, stage 3, but for sure, for the stage, particularly for the stage 2 and also for the overall survival, we definitely need long-term follow-up to have a clearer picture on the benefit also in this lower risk patient population, where we start seeing a separation of the curve around year 2 and 3. In terms of other systemic treatment options, just wanted to remind that in BRCA carriers, including those patients with hormone receptor-positive disease and high risk feature based on the Olympia trial criteria, there is indication to give 1 year of adjuvant olaparib that provides an improvement in both invasive disease-free survival as well as in overall survival. The study has not provided updates in 2023, but was updated at the end of 2022. Final news in the systemic treatment for this disease is the use of immunotherapy in the neoadjuvant setting for a subset of patients with luminal-like tumors. 2 trials have provided evidence in these regards. The first one is the Checkmate 7FL trial that have looked into the addition of nivolumab to anthracycline taxane-based chemotherapy. Most of the patients with a grade 3 tumor, almost all of them, so a really luminal B-like biology. In this patient with a more aggressive luminal-like tumor, we see around 10% improvement in pathologic complete response with the addition of immunotherapy to standard chemotherapy. And as updated in San Antonio, these results are particularly observed in patients with PD-L1 positive tumor, and the lower the expression of ER, the larger the expected benefit with the addition of an immune checkpoint inhibitor. Very consistent findings in the Keynote 756 trial, similar design, anthracycline taxane-based chemotherapy with or without an immune checkpoint inhibitor, pembrolizumab in this study. In this trial, all patients had a grade 3 tumor and more than 1,200 patients were randomized. Around 10% improvement in pathologic complete response overall, and as shown in the prior study, similar findings, more benefit with the inclusion of immunotherapy in PD-L1 positive tumor, as well as the lower the expression of ER, particularly in those patients with the ER level less than 10%. Finally, some updates on survivorship, starting with the importance of stressing the concept of bone health and managing properly bone health in patients receiving adjuvant endocrine therapy. And for this management of bone health, we should also consider the use of bone-targeted agents in those patients receiving endocrine therapy, particularly in the postmenopausal setting that include premenopausal women receiving ovarian function suppression. In terms of other survivorship issue, I'm going to spend a few slides on pregnant after breast cancer because we have had in 2023 many important studies that provided evidence to support the safety of pregnancy in the specific cohort of patients with hormone receptor-positive breast cancer. I want to stress the fact that still breast cancer survivors have very low chances to have a future pregnancy, much lower than that women in the healthy general population and survivors of other type of cancer. And one of the main reasons is that still many of us, many oncologists, are concerned that a pregnancy may increase the risk of recurrence. And this seems to be the case, particularly when we consider patients with hormone receptor-positive breast cancer. However, now we have several studies that have looked into this topic. This is a meta-analysis specifically focusing on safety of pregnancy in hormone receptor-positive breast cancer, showing that following proper treatment and follow-up, and in this case was 5 years of adjuvant endocrine therapy in most of the studies, we don't see any detrimental effect of pregnancy after breast cancer or a tendency for a protective effect of pregnancy following treatment completion. We also now have data to support the use, a potential endocrine therapy break for selected patients with hormone receptor-positive disease. This is based on the positive trial, a prospective study that included more than 500 patients with a strong pregnancy desire, age less than 42 years, that completed between 18 to 30 months of endocrine therapy, and they were eligible to stop the treatment for 2 years to try to have a pregnancy during this break, and then go back to endocrine therapy before completing the treatment. And based on, and if we look, before looking at the results, I wanted to stress the patient population included in this study, with half of the patients having a stage 1 disease, more than 40% receiving tamoxifen alone as adjuvant endocrine therapy, so the treatment option we give to patients at low risk of this recurrence, and more than 1/3 of the patients that did not receive prior chemotherapy. With this caveat in mind and a still quite short follow-up, we see that this approach is safe, so we can recommend this, we can suggest this approach to patients with a strong pregnancy desire that don't want to wait 5 years of endocrine therapy, having a relatively low risk of this recurrence. In the subgroup analysis, I wanted to stress that patients with N2, N3 disease, like those patients that will be eligible to PARP inhibitor if adjuvant olaparib, if BRCA mutated, adjuvant abemaciclib. In the other cases, still there is a quite high risk of this recurrence, probably not related to pregnancy or the endocrine therapy break, but to me related mostly to the disease itself that has a quite high risk of this recurrence in the first 5 years. In terms of updates from this study in 2023 at the San Antonio conference, the author have reported safety data on the use of fertility preservation procedure in this patient, showing that at the time of diagnosis, particularly, the use of fertility preservation procedure does not increase the risk of recurrence. So additional evidence that fertility preservation procedure is safe also in patients with ER-positive early breast cancer. Here, my algorithm to apply the results of the positive trial in clinical practice. First, strong desire of the patient should be the starting point. I will not proactively discuss the endocrine therapy break with my patient, but those patients that have a very strong desire of pregnancy, if they have a low risk of this recurrence and they want to stop the treatment, I think we have evidence to support this break for 2 years. Still low risk of this recurrence, not really a reason to stop the treatment. Maybe the patient is very, very young. There is no really ethical or personal reason to stop right now the treatment. In this case, I will probably still go to 5 years of endocrine therapy. On the other side, the high risk of this recurrence, I will definitely wait 5 years of endocrine therapy and follow up before considering pregnancy. But I also acknowledge, and I have in clinical practice patients that no matter my counseling, they really want to stop the treatment to have a pregnancy. In this case, I would strongly suggest to restage the patient during the washout period of endocrine therapy, just to be sure not to have bad surprise in the first trimester of pregnancy when no systemic treatment can be given during pregnancy. Finally, in this field, a recent study presented at San Antonio and published in JAMA on safety of pregnancy in the specific cohort of BRCA carriers, and there was also a part of the patient included in this study had a hormone receptor-positive disease. Also in this setting, we have now reassuring data supporting the safety of pregnancy also in patients with hormone receptor-positive disease. My conclusion, going back to the ESMO guidelines, adjuvant endocrine therapy in hormone receptor-positive breast cancer in premenopausal patients, low risk of disease recurrence, tamoxifen alone, still standard of care. In all the other patients, the inclusion of ovarian function suppression should be considered as, I would say, the most important treatment, and then the choice of tamoxifen and AI to be combined with OFS based on different criteria, and to me the most important one being the risk of recurrence. The higher, the more I will give AI as compared to tamoxifen, together with OFS, of course. In postmenopausal patients, I have not provided updates on this regard. There were no real study in 2023 in this field. AI-based treatment for 5 years or extended beyond 5 years in patient at high risk of disease recurrence. In the other patient, the possibility to start with tamoxifen and switch to AI after the first 2-3 years. In terms of other systemic treatment, we should remind that on the top of chemotherapy, we now have the possibility to combine targeted treatment option with endocrine therapy, being abemaciclib for 2 years in patients that will fit into the monarchy criteria, or adjuvant olaparib for 1 year in patients that will fit with the Olympia trial criteria. And finally, the reassuring data on pregnancy after breast cancer will stress the importance to perform a proper oncofertility counseling in all young women with breast cancer, including patients with hormone receptor-positive disease. And with that, I really wish to thank you for your attention and again for the opportunity to be part of the OncoAlert Colloquium. Thank you very much.
Dear all, my name is Evandro Azambuja, a medical oncologist from the Julius Bordet Institute in Brussels in Belgium, and it's my pleasure to be here today for this OncoAlert Colloquium 2023 to discuss the news in HER2-positive early breast cancer. These are my conflicts of interest. I'm going to start with a clinical trial that was presented last year and we had subsequent translational research, the PERGAIN trial. The PERGAIN trial includes patients with centrally confirmed HER2-positive stage 1 to 3A early breast cancer. They should have a tumor diameter at least of 1.5 centimeters by MRI or ultrasound, and they should have a PET scan with an available lesion in the breast. So they had different groups, and this time they presented the 3 years invasive disease-free survival. That was the primary endpoint of this study in Group B. The Group A received the chemotherapy, went to PET scan, and continued chemotherapy, went to surgery, and then treatment afterwards. The Group B was a particular group. What happened here? Patients in Group B, they had a PET scan, they received pertuzumab, trastuzumab alone, no chemotherapy, and therapy hormonal if they were hormone receptor positive. They went after 6 weeks to a second PET scan. If the PET scan showed no response, the patient would receive docetaxel, carboplatin, pertuzumab, trastuzumab, and would go to surgery. If the patient had a metabolic response at 6 weeks, the patient would continue on anti-HER2 drugs alone with endocrine therapy for hormone receptor positive, then would go to surgery. What was particular here in this Group B, this upper part, if the patient was a PCR only with pertuzumab, trastuzumab, and endocrine therapy for hormone receptor, they would continue on anti-HER2 drugs, no chemotherapy. If they had residual disease, they would receive adjuvant chemotherapy. And for that group that had no response and received neoadjuvant chemotherapy, they would complete pertuzumab, trastuzumab, plus minus endocrine therapy. This trial, the Group A with chemotherapy, Group B without chemotherapy, that the group that I described now, 285 patients, so about 51% premenopause, 92% a good performance status, 76% unilateral disease, and the stage 2 and 76%, stage 3 and 14%. They also look in terms of lymph node status, 49, about half of them lymph node positive, half lymph node negative, and 32% were hormone receptor negative, and all were centrally confirmed HER2 positive. So they showed the pathological complete response that was 37.9%. So it crossed the boundary for the statistically significant. But now what they showed was the primary endpoint, 3 years invasive disease-free survival in this group B that I just described. And as you can see, the curves are very excellent. At 3 years, the invasive disease-free survival rate is 95.4%, which was considered statistically significant. So they were expecting less than 15 patients with events, and they had only 12 patients. So it's a positive trial. They also looked into different outcomes here, and here is just the survival outcomes. As you can see, the group A with chemo, the group B was split, group B chemo, group B without chemo, only on tier 2 drugs. As you can see, the 3 years invasive survival is excellent even without chemotherapy. The 3 years invasive distant disease survival equally excellent in the group B without chemo, 100%. Event-free survival and overall survival equally very good. What they did third that was presented was the HER2-DX in this trial. The HER2-DX is a kind of score that integrates the tumor sites, the nodal states, and there are 4 gene expression signatures related to immune infiltration, proliferation, luminal differentiation, and the expression of HER2 amplicon. And this test can, one, predict the likelihood of PCR or non-PCR, and also try to identify those patients who have a better prognosis. So what they did in the per game, they looked into these patients. So they score in the group with no chemotherapy, group B. So high score, according to the HER2-DX, 45%, median score 32%, a low score 21%. And then they looked into those patients at the 3 years, those who had relapse is those who had no relapse. As you can see, all patients with relapse, 100%, 12 patients, all of them, they were considered a high-risk patients as per HER2-DX. Those patients without relapse, 62% were high risk, 38% were low risk. And they also looked into according to the 3 years invasive disease-free survival by PCR status. So here, in this first plot on your left-hand side, you see those patients with pathological complete response, they had a very good outcome, 99%. Those with residual disease, they had some relapses, a little less good outcome, 93%. And then, which is interesting, for those patients with residual disease, even there, you can discriminate patients with a good prognosis and a bad prognosis. Those patients with residual disease, if they had a low HER2-DX score, they had an excellent 3 years invasive disease to survive, 100%. And if they had a high risk and residual disease, they had a worse outcome. This signature was also being tested in a combined analysis of 4 neoadjuvant trials, and it was presented at ESMO Breast 2023. So what they did here, they combined 4 neoadjuvant courses, COGB 4601, I-SPY 2, Daphne, and the GOM. So they had 568 patients, all of them treated with neoadjuvant trastuzumab, multi-agent chemotherapy in 50%, single taxane in 40%, pertuzumab almost 50%, lapatinib 18%. And then they did some multivariable logistic regression to see how we can estimate the PCR for PCR status in this trial. And they did interaction tests. So what they looked first is that the HER2-DX is significantly associated with pathological complete response in multivariable analysis. So if you have the PCR score every 10 units increment, you increase the likelihood of pathological complete response. And you can see those group with HER2-DX high, they have 11 times more chance of having a pathological complete response. You could identify also those patients with N2, N3, they had less pathological complete, and those with HER2 enriched, they had a high pathological complete response rate as expected. Then they went further in this pooling analysis. They looked according to the hormone receptor status, hormone receptor positive, hormone receptor negative, and in both of them, the HER2-DX was associated with PCR, regardless of the hormone receptor status, and regardless of dual or single HER2 blockade. And what is interesting here for the HER2 blockades, they look at the overall population, the pathological complete response with dual HER2 blockade was 58% compared to 44% with single blockade, thus a delta of 13%. And if you look into those with dual blockade, that is the dark green, if you look in those with HER2-DX PCR low, there is a numerical increment about 5%. Those with HER2-DX PCR medium, also a 5% increment. And those with HER2-DX PCR high, they increase from 60% with single blockade to 86% with dual blockade. So a 26% increase in pathological complete response in the interaction test was positive. So HER2-DX predicts the response to dual HER2 blockade. Another study that was presented now in San Antonio last year, the APT-NEW trial. Here, patients with locally advanced or operable breast cancer, HER2 positive, chemo-naive patients, 661 patients. They were randomized 1-to-1 to arm A, that was paclitaxel, carboplatin, pertuzumab, trastuzumab, or arm B, that's chemotherapy with immunotherapy. So B1, 3 times AC, followed by pertuzumab, trastuzumab, paclitaxel, carboplatin, plus atezolizumab, or paclitaxel, pertuzumab, trastuzumab, carboplatin, plus atezolizumab, no anthracycline before surgery. And then the patients continue with the same treatment assigned without pertuzumab, trastuzumab, without or with atezolizumab to complete 1 year of treatment. But if you compare arm A, arm B, there was no difference in pathological complete response. It was just a numerical increase. But when you look into those with B1 that were anthracycline and taxane pretreated with dual blockade and atezolizumab compared to arm A that's no anthracycline, no atezolizumab, there was almost 10% improvement in pathological complete response. They also did a multivariate analysis to see the likelihood of PCR, and here the treatment was important for PCR, B1 versus A, meaning anthracycline, taxane, dual blockade, and atezolizumab compared to taxane, carboplatin, dual blockade. PD-L1 positive had more chance of pathological complete response, hormone receptors negative, and if they had a high stromal Ts in arm B1 compared to arm A. So showing that anthracycline is important in this patient population, but atezolizumab also improved the pathological complete response, but I don't think this is going to change clinics because they already had other trials with HER2 positive that were negative for outcomes. Then the German trials, the adapted TP trial. This trial, patients with hormone receptor positive, HER2 positive early breast cancer, they were randomized to receive T-DM1 alone, T-DM1 plus endocrine therapy, or trastuzumab plus endocrine therapy. And they would have treatment for 12 weeks, and then they would go to surgery. And then the primary endpoint was pathological complete response. 375 patients were included in this trial. And the pathological complete response with trastuzumab endocrine therapy alone was quite low, 15% only. With T-DM1 was 41%, and with T-DM1 plus endocrine therapy, 41%. So giving T-DM1 in the neoadjuvant setting improved pathological complete response, but adding endocrine therapy to T-DM1 does not improve. But what is interesting here, that the outcomes of these patients, the invasive disease survival at some years is very interesting because you can see that the curves are very one on top of the other almost. There is no difference if you give T-DM1 endocrine therapy or trastuzumab plus endocrine therapy alone. Equally, overall survival is very similar in the three. So some patients you can de-escalate therapy, and they also looked at tumors with PI3K wild type, high immunomarker expression, and luminal A tumors by PAM50, they had an excellent prognosis if they escalated until to therapy. So you really need to fine-tune some patients that you could avoid chemotherapy in those patients. And moving on with the German trials, the adapted TP2 trial, in this case, patients with CT1C or CT4C and 023 confirmed they are two positive, hormone receptor positive. 207 patients were randomized to receive endocrine therapy if they were premenopausal to tamoxifen alone, if they were premenopausal to anastrozole, letrozole, or exemestane, with dual anti-HER2 blockade, trastuzumab and pertuzumab. The second arm was paclitaxel standard dose with trastuzumab, pertuzumab. Patients received in both arms 12 weeks of neoadjuvant therapy. They would go to surgery. Here, the pathological complete response, as you can see in this table, with dual blockade endocrine therapy alone is 24%, with paclitaxel and dual blockade 56%, showing that you increase the pathological complete response even the hormone receptor positive. The short air trial that it was very much weighted long-term follow-up is a trial that looked into anthracycline taxane-based chemotherapy with 1 year trastuzumab versus a short duration of trastuzumab. And what happened, this trial already was presented before and showed that the short duration could not demonstrate non-inferiority compared to the 1 year. So 1 year was the standard duration of adjuvant trastuzumab. As you can see here, now they have a median follow-up of 9 years, and they just present the survival data for this trial, which was presented and published in the JCO. The disease-free survival 10 years was equal in the two treatment arms, 77-78, and overall survival equal in the two treatment arms, 88, 89, and 88%. But again, I have to say that the trial was negative, could not demonstrate statistical non-inferiority on this, so you should not use, although the curves are very similar, you cannot say that there is no detrimental effect with short duration. On the opposite side, those patients with stage 3 or 4 or more positive lymph nodes, those patients are clearly benefit from for the long duration, 1 year of trastuzumab compared to the short duration. So this trial confirms that 1 year of trastuzumab remains the standard of care. And today, what we do de-escalation or escalation. Those patients with remote tumor, they are treated with 12 weeks paclitaxel, no anthracycline, and 1 year trastuzumab. So we already de-escalate the chemotherapy. Those patients with high volume of disease like node positive, they are treated with trastuzumab and pertuzumab on top of trastuzumab. So this trial you cannot use, maybe could be used in some countries where they have some financial problems. So a short duration, other trials with short duration, 6 months versus 1 year, like the UK trial, also showed that is the only trial that showed that no inferiority of 6 months versus 1 year. So this could be used the basis for some countries, but countries that can afford to pay the total duration 1 year remain the standard duration today. And also the Catherine trial that was very much weighted the long-term follow-up. Here, the trialists present the results with a median follow-up of 8.4 years. So just remind, the Catherine was a very pragmatic trial. Patients receiving neoadjuvant chemotherapy, at least 6 cycles of chemo, and at least 9 weeks of anti-HER2 drugs. It could be anti-HER2 drug, trastuzumab alone, or dual blockade, that was in about 18%. And they had to have residual disease after the neoadjuvant treatment. So in this trial, 1,486 patients were randomized to receive T-DM1 for 14 cycles if they had the residual disease, or to continue with trastuzumab for 14 cycles with the residual disease. So what they showed now is the update invasive disease-free survival. The 7 years invasive-free survival today, the benefit of change to T-DM1 in case of residual disease is 13.7% at 7 years. So patients who continue with trastuzumab and residual disease, they had a 7 years invasive disease-free survival of 67.1% compared to 80.8% with T-DM1. So there is no doubt that it improves the invasive disease-free survival, hazard ratio 0.4, 54 is statistically significant, clinically very much important for our patients. And they did a new updated subgroup analysis for IDFS, and they can see that all subgroups benefit from having TDM1 if they had a residual disease, independent of hormone receptor status, if they received single dual blockade in the neoadjuvant set, if they had node positive or node positive or node negative. All subgroups benefit equally if they had a large amount of residual disease or a small amount of residual disease. And now what was very much expected was the overall survival results. And now you can see that clearly at 7 years, there is a 4.7% absolute improvement in overall survival when you give TDM1 for patients with residual disease. This overall survival is 84.4% with trastuzumab alone, 89.1% with TDM1. Hazard ratio 0.66, statistically significant, extremely important for our patients. So there is no reason to not give TDM1 for patients with residual disease. You must remember that there are some other trials that are testing new ADC compared to TDM1 or TDM1 to tucatinib in the post and neoadjuvant setting, and you have to wait the results. But today, the standard of care for patients receiving neoadjuvant chemotherapy and anti-HER2 drugs who have residual disease at surgery is to switch to TDM1 in the post and neoadjuvant setting. Toxicity was expected, is well known from TDM1, you know, very few cardiac disorders. We had some hematological problems like thrombopenia with that, and some neuropathy, but nothing major. Is a quite safe drug. Also, what is interesting to see that ASCO last year, they did a meta-analysis using 5 out of the 7 randomized trials compared chemotherapy versus chemotherapy trastuzumab. Here they had a median follow-up of 10 years, and they had 53% hormone receptor positive, 87% node positive. They got data from important trials, the pivotal trials, NSVP B31, the FINAIR trial, HERA trial, the 9831, and the PAC04 trial. So they had a lot of patients to see how many patients had TILs. So all trials in total include 11,000 patients, over 11,000 patients, and this analysis 4,168, 36% of the patient population. What they showed that the interquartile range for TILs is variable between 5 and 30%, but the median was 13%, and only 10% of the cases they had TILs above 50%. They first looked into the prognostic effect of TILs on recurrence. And then they look into ER poor, 1972 patients, and ER positive, 2,193 patients. As you can see, higher the TILs, less the chance of having a relapse. So it is a prognostic. They also looked into whether the amount of TILs is predictive of response to anti-HER2 drugs. And here you can see TILs between 0 and 90%. The benefit of adding trastuzumab to chemotherapy is 11.4%. For those with 10 to 39, 8.7%. Those with 4 or more percent plus TILs, 9.5%. So it could not demonstrate a predictive value in this case. So the conclusion of this summary of the TILs is it confirms the prognostic effect of TILs in this patient population. There is no evidence of a natural cutoff. For every 10% increase in TILs rate, the recurrence decreases by 14%. No group with a very low risk of recurrence was identified. And a small number of patients with high levels or node-negative tumors. But also there was no evidence of interaction between TILs and effect of trastuzumab, what is demonstrated in the FINAIR trial. But FINAIR trial compared a short duration of trastuzumab versus no trastuzumab. And the final study that I want to present is a sub-analysis of the affinity trial that was performed by our group, presented by Elisa Agostinetto in San Antonio 2023. Just to remember, the affinity trial is a pivotal trial looking for patients with hormone receptor positive, hormone receptor negative, HER2 positive, and adjuvant treatment for early breast cancer. So in this trial, 4,805 patients were randomized to receive chemotherapy, trastuzumab, pertuzumab. So it was the test of dual blockade or chemotherapy, trastuzumab, placebo. The trial was positive, already presented results. It's positive for invasive disease-free survival and continuous follow-up for overall survival. So what we did here, we looked into the HER2 FISH amplification rate, and here you categorize low versus high, and low is a FISH between 2 and 5, and high is a FISH ratio greater or equal than 5. And also looking according to the expression of ER status. So negative is less than 1% and positive is 1 or more %. You also did another analysis looking for 10% cutoff that you have been used. So included here in this analysis, 4,782 patients, which is 995% of the entire trial population, is a very good accrual of patients. As you can see in this forest plot, FISH high, ER high, FISH high, ER low, ER negative, FISH low, ER positive, or FISH low, ER negative. There is the benefit of adding pertuzumab was consistent across all ER status and FISH ratio groups. So there is a benefit in terms of invasive disease-free survival. The median follow-up for this analysis is 74 months, and we did another analysis using the cutoff of 10%, as I mentioned, and again, you see a similar result. So we cannot say that there is a group that would not benefit in this population from the addition of pertuzumab to trastuzumab in chemotherapy. To summarize, the PERGAN and adapted trial, they confirm that there are some patients you can de-escalate treatment. It's possible and safe for selected patients. We need to identify clearly those patients. HER2-DX score is a promising tool and prospective validation is required. 1 year of adjuvant HER2 therapy remains a standard of care. The post-neoadjuvant TDM1 prolongs now overall survival for patients with residual disease after neoadjuvant chemotherapy and HER2 drugs. TILS is a prognostic, but is not predictive of the benefit of trastuzumab in the patient population that was analyzed. And the invasive disease-free survival benefit from the addition of pertuzumab to trastuzumab in chemotherapy was consistent across all ER states, the FISH ratio subgroups in a sub-analysis of affinity. With this, I would like to thank you for your attention. And thank you very much for watching this, and hope to see you in the next episode of OncoAlert Colloquium.
Hi, my name is Janice Cowden, and I'm a patient advocate diagnosed with metastatic triple-negative breast cancer in 2016. It's an honor to be invited by OncoAlert to provide my views on breast cancer research and what was meaningful to patients in 2023. You'll hear updates from several distinguished breast cancer experts about the latest research and drug development, but I'm here to provide the patient perspective. I was fortunate to have the opportunity to attend multiple scientific cancer meetings in 2023, including 2 international breast cancer conferences, ESMO Breast in Berlin and ABC7 in Lisbon. These experiences played a pivotal role in shaping my perspective on what was impactful, while also offering clarity on current gaps and unmet needs. 3 words come to mind looking back on 2023: collaboration, communication, and quality of life. At nearly every conference I attended last year, a consistent message resonated: inclusion of patients in cancer research and providing them a voice at scientific conferences is important, and not just to patients. For example, at ESMO Breast in Berlin, patient advocates chaired sessions and participated as panelists. They spoke from the audience about their personal experiences participating in clinical trials, and encouraged the importance of research. A great example of the importance of including patients in all aspects of cancer care and research was Dr. Eric Weiner's presidential theme for the ASCO 2023 annual meeting, Partnering with Patients, the cornerstone of clinical care and research. He received a deserved standing ovation after the delivery of his welcome address at ASCO's annual meeting in June. His theme was shaped by both his professional experience as a clinical oncologist and his lived experience as a patient with a serious illness. Patients are the sole reliable source of information for assessing quality of life, yet their voice isn't consistently prioritized in clinical trial design, reported outcomes, and study publications. There's substantial room for improvement in this area, in my opinion. Patients should be included in clinical trial design from the beginning. And one example where patient voice is missing is in analysis and reporting of quality of life from early phase clinical trials to post-marketing. Current methods of analyzing and reporting safety and tolerability lack important information in terms of quality of life, and it's more about safety than tolerability. Our current adverse event grading system is flawed as a method of assessing tolerability in the real world. While grade 2 may be considered a mild adverse event, for a patient experiencing grade 2 diarrhea, that's an additional 4 to 6 trips to the bathroom every day. I doubt most healthcare providers would consider that a tolerable disruption during their workday or their daily life. I recently attended a webinar on cancer treatment-related GI toxicities in supportive care, and some key takeaways for me from this webinar included the lack of quality of life as an endpoint in clinical trial design and outcomes reporting. I learned that in a review of phase 3 clinical trials from the past decade, fewer than half incorporated quality of life as an endpoint, and furthermore, only 38% of these trials included quality of life outcomes in the primary study publication. Consequently, when study results are initially published, quality of life information is often missing. And the median time for publication of a secondary paper containing that quality of life data was 34 months, nearly 3 years. That's unacceptable. Consider how this affects clinicians and patients. We hear a lot about the importance of shared decision-making between patients and healthcare providers, but if quality of life information isn't available for a newly approved cancer drug, there's important information missing that helps guide both physicians and patients in terms of quality of life when choosing the best treatment option. This could be improved by utilizing PROs, including quality of life as an endpoint in phase 3 clinical trials, and including this information in the primary study publication. Now, speaking of successful collaboration, I'd like to highlight a great initiative that was designed by researchers and patient advocates and implemented at the 10th annual NBCRC conference last August in Park City, Utah. Spearheaded by Dr. Hillary Stiers Andrews, MARP, which stands for an Advocate Researcher Program, successfully brought 20 paired advocates and researchers together, and most had little or no experience collaborating in basic or translational research settings. At ABC 7, I participated in the ABC Global Alliance working session, where we discussed hard topics like end-of-life discussions and how we can improve these conversations. And the final day of the meeting included a review of the ABC Global Charter, where a diverse group of Alliance members participated in a speed dating type version of roundtable discussions to capture current gaps and future needs to ensure quality care for all patients living with advanced breast cancer across the globe. 2023 was a phenomenal year for the long-awaited new FDA-approved targeted therapies for hormone-positive metastatic breast cancer with elacestrant and capivasertib, adding FDA approval of sacituzumab govitecan for hormone-positive MBC in 2023 increased treatment options for more patients with metastatic breast cancer. A huge highlight of 2023 for me was having the privilege to serve as a patient advocate panelist in a special session at the San Antonio Breast Cancer Symposium titled New Drug Approvals for Metastatic Breast Cancer. During this session, patients and healthcare providers alike questioned the FDA's decision to limit approval of these new targeted therapies to those patients with ER-positive metastatic breast cancer harboring certain mutations, such as ESR1, PIK3, and AKT. Patients were anxiously awaiting these new approvals, but were very disappointed to learn of the limited access to these new drugs. Having additional treatment options is important, but equally important is that these new drugs work better than existing standard of care therapies and with fewer toxicities to preserve quality of life for patients. Moving toward patient-centered medicine, we need to be sure we're getting the right drug to the right patient at the right dose. There are still areas that need to be addressed, including drug resistance, sequencing of targeted therapies, access to and diversity in clinical trial participation, and more treatment options for triple-negative breast cancer. And finally, I would like to thank OncoAlert for this opportunity to provide my perspective on the breast cancer landscape of 2023, and thank you for listening.
Hello everyone, my name is Giuseppe Catanuto. I work in Catania, Italy at Marito Sistema Clinico Catanese. I'm also the president of Fondazione Greta ETS, which is a foundation dealing with research and education in surgical oncology of the breast and oncoplastic surgery. And my topic today will be about advances on surgical oncology of the breast during year 2023. And I want to start my presentation, with my next slide, which is about data from the National Agency for Health Services in Italy, AGENAS, about the breast conservation rate, which in Italy is about 70%. That accounts for approximately still 20,000 mastectomies. Now, we know that this breast conservation rate is quite good across Europe, but we still want to improve these, and 20,000 mastectomies is a huge burden for either the national health systems and the patients themselves. You know that breast reconstruction nowadays is either complex or poor procedure. It's complex procedure if you want to use autologous tissue-based breast reconstruction, which protects quality of life, but on the other side generates high costs for the NHS, long operating times, you need skilled microsurgeons, and you need the good patient candidate to the surgery. And then on the other side, you have implants, which are very easy technique in the hands of nearly everyone who can do a mastectomy, but still poor results with a lot of compromises in terms of quality of life, a come and go from theater to change the implant, and possibly breast implant illness associated, and impact of the foreign body, the silicone foreign body on the immune system. And obviously, we don't want to talk about a very rare disease that is the ALCL, the BIALCL. In Italy, we've been talking about surgical de-escalation in the last 50 years, and the first trial was the Milano one, back in the 70s. And this trial was about breast preservation, and so de-escalation from mastectomy to breast conservation in unifocal lesions. It was a randomized trial and was followed by the NSABP BO6. Even that one was on unifocal lesions, but you know, at that time, the assessment was very poor. We had very limited diagnostic tools. The multidisciplinary management was so poor. So at the beginning of this millennium, of year 2000, we had the chance to save a breast in unifocal lesions. But the question was, how can we preserve the gland even when the cancer is multiple and is multifocal or multicentric disease? You know that also even in the other disciplines, there is a search for de-escalation and escalation to create the proper tailored management to patients. And we have very important trials in the radiotherapy setting, like the B51, the Alliance 11202, which are taking advantages from primary systemic treatment. And at the same time, we know that primary systemic treatment is warranting a very high chance of pathological complete response. But what we want to do, we want to translate all this information, all these new tools that we have, these new multidisciplinary tools, into a better quality of life and preservation of the breast in clinical practice. So what is clinical question number one that we want to address according to the evidence that we have from year 2023? This is, can we avoid the mastectomy in multiple ipsilateral breast cancers? We have very good data from a systematic review published by Zoe Winters in 2018 that is showing that there is no difference in local regional control in the comparison between mastectomy and breast conservation in multiple ipsilateral breast cancers. They tried to set up a trial, which was the Miami trial, but the recruitment of patients was very difficult. Patients had a lot of ethics concerns about the possibility of being randomized to have a mastectomy, or on the other side to have a therapeutic mammoplasty for breast preservation. So the trial basically failed. The accrual was very poor. Only 20 patients were deemed eligible, but only 4 accepted randomization. For this reason, we have to rely nowadays on the evidence from the Z11102 Alliance trial that was published in 2023. These conclusions are very interesting. This trial was not really a comparative trial, was a multicentric prospective single-arm study, including patients of 40 years or more with histological confirmation of invasive breast cancer in at least one of the sites, plus an additional site that could be a DCIS or another invasive cancer, and patients post-neoadjuvant treatment were excluded. The distance between the index focus and the other focus was 2-3 centimeters on clinical examination or imaging, and the disease extent has to be limited to 2 quadrants of the breast. And they applied at the very beginning the 2 millimeters policy that was changed by agreement with the major American societies to the no income tumor policy, and the oncoplastic closure was allowed. The primary endpoint of the study was the assessment of the local recurrence rate. Now, we know that in unifocal breast cancer, we have an approximately 1% at 10 years, in 10 years rate of 1% year local recurrence rate for an approximately 10 to 12% of local recurrence rate at 10 years. That is considered acceptable. And in other retrospective studies about multicentric cancer, the 5-year local recurrence rate was from 3 to 11%. So the authors considered a less than 8% local recurrence rate an acceptable rate at 5 years. And these are the results. They recruited 204 patients with a median age of 61 years. And the majority of the patients had 2 foci, only 7 patients had 3 sites involved. And the median shortest distance between lesions on imaging was 4 centimeters. And in 30% of the cases, the procedure was a single lumpectomy. In 70% of the cases was a multiple approach. That obviously could have included also oncoplastic surgery. And it is very interesting to notice that the receptor status was different in the second lesion in approximately 10% of the cases, and that 49 patients had a DCIS focus associated to the index lesion. These are the Kaplan-Meier curves. after a median follow-up of 66.4 months, approximately 3% local recurrence rate, which is absolutely in keeping with what was the original threshold of less than 8%, even considering the 95% confidence interval. So very, very reassuring results, and we can perform this. Some of very important information that we can get from this trial is that systemic treatment is working, is preventing local recurrences. This can be easily seen in patients who had endocrine positive disease who did not receive estrogen receptor positive disease who did not receive adjuvant endocrine treatment, for which the 5-year local recurrence rate was 12.5% versus 1.9% in patients who did receive adjuvant endocrine treatment. So once again, the impact of systemic treatment in a modern multidisciplinary setting is one of the determinants of the success of our surgical procedure. And also it was very important to notice, it is very important to notice the impact of MRI, because MRI was used at the very beginning extensively and identified a second malignant lesion not seen in the ultrasound or in the mammogram in 72 patients, which is approximately 42%, so a very high percentage. And patients who had an MRI had a very, very low recurrence rate, 1.7%, compared to patients who did not have an MRI, who reported a recurrence rate that was 22.6%, so a very high local recurrence rate. Obviously, this study had several limitations. First of all, the sample size that was designed to get information on the local recurrence rate, but the analysis on the subgroups are not really reliable, very narrow subgroups. And unfortunately, post-neoadjuvant patients had to be excluded from this series, and few patients had 3 lesions, and therefore we have few information on HER2 positive triple negative breast cancer that obviously had primary systemic treatment. And of course, 5 years for estrogen receptor positive cancers is quite a narrow follow-up. So clinical question number 2 now is, according to evidence that we had in 2023, can we safely avoid a mastectomy using neoadjuvant chemotherapy? So can we use neoadjuvant chemotherapy in a safe way to downstage our patients and to reduce the surgical burden? Well, in 2018, we had the report of the Early Breast Cancer Trialist Cooperative Group, which was quite worrying, with a 21.4 local recurrence rate for neoadjuvant patients at 15 years, compared to a 15.9% local recurrence rate in the adjuvant setting. We know that this was not anticipated in historical trials, neither confirmed in more modern trials on neoadjuvant chemotherapy. And we also know that this systematic review and meta-analysis is based on very old studies that were performed outside the modern scenario, target therapies or multidisciplinary management, and so on. What we can see nowadays is still that if we compare historical trials such as the NSABP, well, we can see that we had, at that time, they had a pathological complete response rate of 13% compared to a breast conservation rate of 60 up to 68%. That means that even though the pathological complete response was very low, the breast conservation rate was high. And nowadays, the situation is completely different, because with modern trials, for instance, in the setting of triple negative breast cancer with the 603 trial from the CA-LGB, you can see that the PCR rate is up to 60%, and the breast conservation rate is only 47%. And even in the HER2 positive setting, you can see that using only trastuzumab, the pathological complete response rate was 25%. It nearly doubled coupling trastuzumab to lapatinib, but once again, the results in terms of breast conservation were really not changed, with a 66 to 68 rate of breast conservation. That means that even though with modern drugs we are having a good rate of pathological complete response, we are not using this pathological complete response to downsize the surgical burden. We are not doing less mastectomies, and this is once again more morbidities, an implant, a complex procedure, complex autologous procedures, a higher burden for either the patient and the national health system. Now, these are the evidence produced by a sub-analysis published on the Annals of Surgery in 2023 by Judy Boogie and the American group. And once again, you can see that the question in this trial was, can we perform safely breast conservation? Is breast conservation safe in the setting of neoadjuvant treatment? So once again, this is not a trial, this is a sub-analysis. You know very well the I-SPY2 trial, which is a multicentric adaptive platform. And in this case, patients were eligible, had tumor, an high-risk tumor, either a triple-negative breast cancer, an HER2-positive breast cancer, hormone receptor positive patients were included with a 70-gene signature of high risk, and breast MRI was used at the baseline at weeks 3, 12, and preoperatively. And obviously, they had multiple neoadjuvant chemotherapy arms, and the primary endpoint was the local recurrence rate and the local regional recurrence-free survival by type of surgery. And this is very interesting. They investigated also the relationship between the residual cancer burden and the local recurrence rates. And you can see this is the population. So mastectomy patients were younger, had an IRT, and more frequently node-positive disease, and a higher residual cancer burden. These are more or less the results. So 92 patients in the study cohort had a local recurrence event. Overall, there were no significant differences in the breast conserving surgery versus mastectomy. These are the results of the univariate analysis. And you can see that on the univariate analysis, tumor receptor subtype, clinical T category, and residual cancer burden were significantly associated with local recurrence rate. And even the multivariate analysis, more or less, same results. And considering that triple negative compared to the reference hormone receptor positive had nearly 3 times higher chance, has a ratio to develop a local recurrence, same for T3, T4 cancers. And very interestingly, once again, residual cancer burden, you see how it increases the risk of having a recurrence from 1 to 2 to 3. But this is irrespective of the surgical technique that we use. And if we look at the Kaplan-Meier curves, if we look in the comparison residual cancer burden, 0 or 1 in mastectomy or breast conservation, you see that is not the technique in changing the outcomes, but really is the residual cancer burden. You can see in blue residual cancer burden, in blue the residual cancer burden 0 or 1, and in brown residual cancer burden 2 or 3. And you can see that it's not the technique that you use that is making the difference. So no association between type of surgery and local recurrence-free survival, and overall survival, depending on the technique you want to use. And residual cancer burden is a strong predictor, but don't forget that residual cancer burden is something that we know after the operation and not before the operation. So it can be still relevant information for the shared decision-making process, discussing with patients the outcomes of surgery, anticipating an higher risk of having a local recurrence, but not information usable in the preoperative setting, in the preoperative planning. So these are the replies that we had in 2023. Can I do breast conservation with multiple ipsilateral breast cancer? Yes, I can do this, but I need a very good surgical oncology approach. That means that I need to plan very well. I need to prevent deformities, but I still need to perform a surgical oncology operation, not a cosmetic operation. So it's a completely different approach. I need to make the tumor bed identifiable. I need to stage before using MRI. I need to identify very well the lesions, and I need to arrange the surgical technique in order to maximize the final outcomes and the local control of disease. And you can see that the results are very good, like in this picture, even for very, very wide excisions involving the medial quadrants in a very large breast like this one. Nowadays, you can do this even in smaller breasts because we have very reliable techniques of tissue replacement, like chest wall perforators flaps. And you can see this lady who did not have who did not have ptosis and had quite a small breast with no ptosis and a bifocal breast cancer in the lateral aspects of the breast, in the lower outer quadrant. And we could perform a chest wall perforator flap using the LICAP and replacing the volume with very good results, with nearly no scars on the breast. But once again, you have to plan these operations, bearing in mind the surgical oncology predicaments. This is not cosmetic surgery. This is not only plastic surgery. We want to get the oncological outcome and the local control of the disease. And what about the effects on neoadjuvant chemotherapy? Yes, we know that neoadjuvant chemotherapy is safe, local control is warranted, and as we have information now that systemic treatment is able to warrant local control together with surgery. But clearly, this is not enough. As we said before, we need to improve the surgical techniques, but also we need to think in a more broad way, and we need to consider also to improve the design of clinical trials in the neoadjuvant setting, because nowadays we have very, very effective drugs that are able to get to pathological complete response in a very high percentage of cases. And in terms of clinical practice, we need to inform patients about multicentric trials and invite patients to adhere to multicentric trials of neoadjuvant chemotherapy for drug developments that can warrant an increased pathological complete response. And finally, we need to improve the diagnostic workup, the localization techniques to get the best results, coupled with more improved surgical techniques. So these are my conclusions. Nowadays, we can reduce these 20,000, at least in Italy, 20,000 mastectomies using either surgical techniques, either new localization techniques, either multidisciplinary management, and primary systemic treatment. This is my hospital in Sicily. Is a brand new breast unit certified by the European Society of Mastology. It's part of the European Commission Initiative for Breast Cancer. It's a very modern breast unit. Everybody is invited to join and come and visit us. Thank you very much for your attention.
I am Icro Meattini, Associate Professor at the University of Florence, Radiation Oncologist, and welcome on 2023 OncoAlert Colloquium on breast cancer and radiation therapy. It's really a great year. This is my disclosure, and this is the agenda. First of all, treatments in early breast cancer, 2023. Accelerated partial breast irradiation. The paper was published at the beginning of the year 2023. The JACASTRO multicenter randomized phase 3 non-inferiority trial based on 16 hospitals that randomized whole breast irradiation as compared to accelerated partial breast irradiation using brachytherapy. with primary endpoint ipsilateral local recurrence. These are the main eligibility criteria. Women aged more than 40 years, T1, T2, and 0 patients with clear surgical margins more than 2 millimeters, receiving a whole breast or a partial breast irradiation. Also, a low or intermediate risk DCIS lesions were allowed for recruitment. These are the results at 10 years. So long-term, 10 years follow-up, local recurrences, 1.58% for the whole breast irradiation arm as compared to 3.5% in the APBI group. The difference between the two arms at 10 years was less than 2%, statistically not significant as for statistical assumptions of the trial. Concerning regional node recurrence, 0.4% in the whole breast irradiation, 1.2% in the partial breast irradiation arm. No difference between arms. No differences also in terms of distant metastasis, disease-free survival, overall survival, and also second primary contralateral tumor incidence. Concerning toxicity, been already published the 5 years results that show favorable impact of partial breast irradiation over whole breast irradiation. And the difference at 10 years is quite similar if you compare whole breast and partial breast, with a grade 3 toxicity of 4% for whole breast irradiation and only 2% for accelerated partial breast irradiation. So this trial provide long-term evidence in favor of accelerated partial breast irradiation in terms of equivalence of local control and a favorable safety and cosmetic outcome. So there are several options to deliver partial breast irradiation, and radiotherapy could be considered as an attractive standard options, although it requires high expertise. And keeping the partial breast irradiation topic at the end of the year on the Practical Radiation Oncology journal, been published the Astro clinical guideline. Was multi-institutional experience that show try to clarify patient selection criteria and the appropriate modality for delivery partial breast irradiation as an alternative to full breast irradiation. As a result of this really interesting paper, partial breast irradiation is recommended for patients with early stage invasive breast cancer that with all the following factors: grade 1 to disease, estrogen receptor positive histology more than 40 years, tumor size less than 2 centimeters. Partial breast irradiation is recommended also for patients affected by DCIS with all the following factors: low to intermediate grade, age more than 40 years, size less than 2 centimeters, with this nice algorithm on your right in the slides. For patients with early stage invasive breast cancer or DCIS receiving partial breast 3-dimensional conformal radiotherapy and intensity modulated radiotherapy is recommended, as well as multi-catheter brachytherapy. There is a lot of debate on the intraoperative radiation therapy studies concerning local relapse results reported in the literature. Concerning early stage invasive breast cancer DCIS receiving external beam partial breast, 30 gray in 5 fractions delivered on non-consecutive days within 2 weeks is recommended, as well as 40 gray in 15 consecutive fractions as per import law trial. The once-daily external beam partial breast irradiation is recommended based on the fewer late toxicities and improved cosmesis, while twice-daily external beam partial breast irradiation, as per rapid trials, not recommended based on poorer cosmetic outcomes, although the trial demonstrated an equivalence in terms of local control. Multicatheter brachytherapy is recommended based on cosmetic outcomes following the fractionation used in within the JAK-ESTRO trial. Conclusion, we have multiple randomized controlled trials that have demonstrated oncologic equivalence between partial breast and whole breast irradiation for the treatment of early stage invasive breast cancer and low risk DCS. We need further efforts to de-escalate local therapy, but not only local therapy, so from both surgical radiation, but also systemic point of view. And concerning de-escalation, has been published in 2023 a very nice study, the Lumina study, omitting radiotherapy after breast conservative surgery in luminal A breast cancer. These were the inclusion criteria: more than 55 years, PT1 and 0 estrogen receptor positive, progesterone receptor positive patients with Ki67 less than 13.25%, and endocrine therapy plan for 5 years that omit adjuvant radiation therapy, null hypothesis of local relapse less than 5 years, and results at 5 years, 2.3% local relapse, and very good effect in terms of disease-free survival and overall survival. It's a very promising study with some key details to be discussed, as the broad inclusion criteria of a lot of patients, where the 40% of patients were less than 65 years old. This could be relevant due to life expectancy considerations and the inter-rater reliability of Ki67 value. That could be problematic. 30% of registered patients were excluded in the screening after central testing due to different Ki67 level. And the Ki67 level regarding the potential indication for systemic therapy is cut off of 13.25%, concerning also the widely used genomic test for these potentially low-risk patients. So it's been really interesting to have a nice discussion from some international authors and the co-authors of the Lumina trial. They try to discuss, and we can follow during this publication on the Green Journal, about the importance of further study trial on the de-escalation of treatment for low-risk patients. So to answer currently the question of the effectiveness of radiotherapy on local relapse, we should follow the PRIME 2 study that has been published, again, 2023, 10 years local relapse rate in patients aged more than 65 years old that receive or not radiation therapy. These are the results at 10 years overall. Patient relapse, local relapse with 10% omitting radiotherapy and less than 1% receiving radiotherapy. If you consider estrogen receptor low patients, this relapse increase to almost 20% in patients that omit radiotherapy as compared to 0% in patients receiving radiotherapy. So it's really a highly debated question. And trend published in 2024, but performed during 2023, has been published the St. Gallen 2023 Early Breast Cancer Consensus Conference, and then recommendations. So the aim was to provide clinical guidance on common situations encountered in early breast cancer treatment and give some useful recommendations to local, regional, and systemic therapy built upon previous recommendations. So we discussed the voting about the early breast cancer at St. Gallen Consensus Conference, about radiation therapy. We talk again about omission of radiotherapy. There's been shown that it increased the incidence significantly of local recurrence, but had no detrimental effect on distant and survival. So needs further study, depending also on the compliance of endocrine therapy. External beam radiation therapy, partial breast radiation therapy for patients with low-risk breast cancer was non-inferior to whole breast irradiation, also in terms of breast in duration, thanks to the Danish trial that showed the favorable impact of partial breast irradiation, irradiating less volume. So partial breast irradiation should be favored over all breast irradiation following the criteria and existing recommendations. Simultaneously integrated boost is safe treatment with reduced patient visit and further escalation of booster dose and does not appear advantages the boost. And the 5-year local control after 26 gray of over 5 fraction is not inferior to 40 gray in 15 fractions following the fast forward trial. In high-income countries, we discussed about them all, nearly 30% new cancer patients are rising, patient age more than 70 years beyond the age of common screening mammography program. So this is something we have further discussed. It is therefore crucial to raise awareness among the general public. It's important to tailor adjuvant therapies to each patient, of course, based on their tumor characteristics, coexisting medical condition, also financial considerations and personal acceptance of the proposed treatments. But 2023 was really interesting also because it's been published on the eClinical Medicine journal, that is a companion journal of the Lancet family, of the Lucerne Toolbox 2, Optimizing Axillary Management for Early Breast Cancer, another multidisciplinary expert consensus. Clinical axillary lobe management has evolved from a surgical, systemic, and radiation therapy aspects. The aim of these consensus was to achieve evidence-based agreement and provide recommendation on axillary management in early breast cancer. There were published several work packages on diagnosis, axillary surgery, pathology, radiation therapy, and outcomes that you can find in this very nice publication, in particular being stratified patients depending on the clinical presentation and their primary systemic therapy response, where we can find recommendation of post-operative radiation therapy based on the clinical presentation and the post-surgical framework. Two main topics in the axillary management require, of course, further discussion. This has been discussed and the main conclusions of the paper, that impact of the advances in surgical technique and modern application of radiation treatment, volume-based therapies should modify and influence treatment recommendation. And again, the possible impact of reduced adjuvant systemic therapy in case of scenarios where fewer lymph nodes are resected and evaluated. So there are a lot of new studies and considerations that are ongoing and needed. Still concerning radiotherapy to regional node, a very important study has been published at the end of the year, the individual patient data meta-analysis on more than 40,000 women deriving from 16 trials based on old and newer trials testing regional node irradiation. The aim of meta-analysis was to assess the effect of regional node radiotherapy in breast cancer recurrence and mortality, reporting separate meta-analysis on newer and older trial. These are the main important results for regional node irradiation show that reduce this overall risk of breast cancer recurrence and breast cancer mortality. The newer trials assess radiotherapy to various sites, generally including the internal mammary nodes. In newer trials, regional node irradiation reduce overall breast cancer, also distant recurrence and overall mortality. Only one of the two newer trials randomized axillary radiotherapy providing lymphedema data. Of course, there was no significant variation in relative risk for any recurrence of breast cancer mortality according to type of breast surgery, nodal regions irradiated, of use of systemic therapy, or follow-up. So these are the main results where node radiotherapy in the early trials had little effect on overall recurrence or breast cancer mortality and increased non-breast cancer mortality. But now the newer trials can benefit from the visualization of radiation dose and cross-section images, especially in radiotherapy planning, irradiation to the chest wall, the most frequent size, local recurrence after mastectomy, irradiation of the lower axilla, demonstrating benefit in terms of regional recurrence in all the setting of recurrence, PN0, PN1 to 3, and especially PN4+. And not only in terms of any recurrence, but also in terms of breast cancer mortality, there is an effect in favor of regional node irradiation on all the group risk, PN0, 1.6%, PN1 to 3, 2.7%, and especially more than 4 positive nodes, where the gain from regional node radiotherapy on mortality is around 4.5%. So the main conclusions of this meta-analysis, the radiotherapy improved further since the newer trial were conducted. Currently, the proportional benefits of regional node irradiation breast cancer recurrence, and that could be even greater than in the newer trials. We are still awaiting of the newest results randomized trial concerning the effect of regional node radiotherapy. And we are waiting for the full paper presentation of the Regional Node Irradiation Alliance trial presented in San Antonio 2023 by Terry Mamunas that demonstrated no benefit for regional node irradiation. So we will see next colloquium the full paper of this important trial. Another important theme is the integration of radiotherapy with target treatment for breast cancer. Among the project of consensus, international consensus that we developed in last year and a half, been published 2 important systematic review of systemic therapy together to radiotherapy. The first one published by Viola Salvestrini and colleagues, published on the Green Journal, evaluate the effect of TDM1 with concurrent radiation therapy based on the systematic review. More than 400 patients identified and then selected on the measured database. In the metastatic setting with intracranial metastatic disease, radiotherapy together to TDM1 increased the incidence of radionecrosis, grade 3 plus radionecrosis, 17% as compared to 10% median in brain stereotactic radiosurgery alone. In the adjuvant setting, conversely, moderate hypofractionation was considered a favorable option for combining postoperative radiotherapy and TDM1 in terms of skin toxic effect. And a low incidence of radiation-related pneumonia was observed in the concurrent arm. Of course, further study needed to enhance the understanding of this combination treatment. And the second part of the project with the paper published first name Carlotta Beccherini and colleagues showed the safety profile of CDK4/6 inhibitors and radiation therapy. Another systematic review, this time published on the Cancer Treatment Review journal to assess the safety of CDK4/6 inhibitors. These are the few studies that have been selected from the literature combining CDK4/6 inhibitor and radiation therapy. Intracranial treatment, these are the main results, were performed in 13% of cases. There was recorded low incidence of radionecrosis, low incidence of interstitial lung disease, no evidence of increased pulmonary toxicity in patients receiving stereotactic body radiotherapy for lung or bone metastasis. So the grade 3 toxicity was around 22% overall, in line with the main pivotal trials published on the CDK4/6 inhibitors use. Also concerning the hematologic toxicity rate, we observed a 14% of grade 3. So basically, was mostly represented by neutropenia as expected and not especially increased by the concurrent radiation therapy. The non-hematological toxicity was 3%. In general, most difficult because based on the volume treated and the site of treatment. Gastrointestinal toxicity was quite frequent, most represented by diarrhea. Only 2 cases grade 1 esophagitis was reported. So really, we have few data and low level of evidence. But it's very nice, this paper that reported some illustrations on the combinatory strategy and the biological rationale of concomitant or sequential of treatment of CDK4/6 inhibitors and radiation therapy that called for further studies. So basically, there's currently no available data on the safety or the efficacy of concurrent radiotherapy CDK4/6 inhibitor in the early breast cancer setting, where the main pivotal trial never tested concurrent radiotherapy and CDK4/6 inhibitors. But in the case of metastatic disease, the results are absolutely encouraging. It may be possible to consider administering CDK4/6 inhibitor and radiation therapy, of course, on a case-by-case basis, taking in considerations several factors such as total dose, irradiated volumes, and weighing the risk and benefit and the compliance of the patients. All these recommendations has been discussed in Florence, Italy last year, presenting an international multidisciplinary consensus on the integration of radiotherapy with new systemic treatments for breast cancer, and ESTRO, European Society for Radiotherapy and Oncology, endorsed recommendation that will be published on 2024 on the Lancet Oncology. Tentative publication expectation is for February 2024. About local regional treatment in metastatic breast cancer, the EORTC and imaging breast cancer group and breast cancer group being published some recommendation on designing clinical trial based on modern imaging and metastasis-directed treatment in patients with oligometastatic breast cancer. The aim was to determine which imaging methods should be used for standard care for oligometastatic breast cancer, and the potential, the benefit of the use of modern imaging to enhance the delivery of metastasis-directed therapy. There was a literature review, definition of standard and modern imaging and combination, and several presented results on the importance of the biology of breast cancer, the site metastatic involvement, the definition of oligometastatic disease, the use of PET-CT and MRI in the definition of oligometastatic disease, the evidence that supports surgery or stereotactic body radiotherapy in the treatment of oligometastatic disease. Of course, very important discussion on the definition of oligometastatic disease to reach the feasibility to safely deliver metastasis-directed therapy with a curative intent. So several suggestions in terms of stratification in trials based on histology and biology of tumors, especially breast cancer, at least several types of randomization trial to compare imaging methods and the main endpoints of the proposed trial, overall survival, progression-free survival, and the importance of health-related quality of life. Another very important trial published on the Green Journal 2023 is on another hot burning topic, that is the re-irradiation. These are the International Pattern Care Survey within the framework of the EORTC E2 Irradiate platform. The aim of this paper was to investigate the patterns of care of re-irradiation internationally. These are the main results, almost 400 participants for 55 countries and 6 continents. The most commonly reported treatment goal for irradiation was prolonging local control across all regions of treatment. We talk about definition of cumulative dose and we discussed the site of re-radiation, especially thorax and abdomen. In the discussion, we discussed about that re-radiation is increasingly used treatment option. Defining safe dose constraints for previously irradiated organs is crucial. It's a central challenge. We have to consider the ability to each tissue before re-irradiation, of course, to receive more doses. It is really crucial to integrate re-irradiation tools in planning system to maintain the standards. And we discussed also limitation. Main conclusion, of course, further studies needed to determine the possible extent and influence factor on recovery from radiation damage. Standards for radiation is the key for each organs in order to compare them through randomized clinical trial. Concerning techniques in radiation therapy, after 2 years of work, we published the Icro guideline on recommendation and implementation of breath hold technique in radiotherapy. Deep inspiration breath hold is one of most effective tool in our hands to reduce the dose to organs at risk when we irradiate patients, especially in the breast cancer treatment. We discussed deeply in all the organs and site of treatment, especially breast cancer, with the first large-scale application of breath hold technique was undergoing radiotherapy, and the aim is basically to reduce the dose to the heart. Of course, the compliance in breast cancer patients is excellent, but we have to work a lot on to increase the compliance of patients, trying to test a coaching for the patient. It's really important to coach the patient to ensure compliance. Few studies compare several deep inspiration breath hold approach, and the voluntary approach is shown to be suitable for three-dimensional conformal radiation therapy breast cancer treatment. So some consideration about the adequate and appropriate time for staff training and patient coaching. To choose the adequate system to be available, all the scanner using radiotherapy planning, CT, PET-CT, MRI to ensure consistencies of all images used for treatment, explaining the importance of daily imaging or not for the verification of the position and target in breath hold, the target-related intra-fraction monitoring, the ability to re-image, replan the patient if any change of breathing pattern is suspected. So this is a very important topic in radiation therapy techniques. And finally, a very important topic about the equity, diversity, and inclusion in radiation therapy. There is a lot of publication. This is one critical review that Pier Francesco Franco and colleagues published 2023, try to focus on the promotion of EDI in radiation therapy. We aim to explore the common patterns in research and emerging trends, tracking collaboration and networks, anticipating future direction in clinical research through a systematic bibliometric analysis of documents published in EDI in radiation therapy. Only papers published in English. This is a limitation, of course. More than 400 documents match our research criteria. What we observed, 1 out of 3 articles were published on the green journal of the red journal, so the first European and American journal for radiation oncology. United States contributed most for publication in this field, followed by Canada and Spain. In the first 10 years, research was primarily addressed cost effectiveness. Only later, over time, the main focus shifts to equity, diversity, and inclusion. There is an increase, of course, interest in EDI. The average annual growth rate is around 20%. This was observed between 2000 and 2022. The predominant, of course, upside in terms of scientific production is the United States and Europe. There are several prompts to improve equity, diversity, and inclusion, eliminating discrimination, harassment within the radiation oncology workforce, mitigating salary inequities, improving the integration between professional and family responsibilities, avoiding disparities in use of different types of treatment. So there are some technical social, professional related topics, promoting investments in infrastructure and machines for radiation therapy, increasing the public awareness of the role of radiation therapy as not harassment, but curative treatment, improving radiotherapy technology, decreasing, where possible, radiotherapy costs, and reducing treatment time for our patients. So EDI has been widely used in various contexts. It's related to a groundbreaking society transformation, potentially affecting professional, public, academic organization. Radiation oncology research must continue to evaluate disparities in cancer treatment outcomes, and how to mitigate these disparities. Of course, all oncology professionals must, should at least, try to transform systems across the spectrum from early detection to the effective treatment for all our patients. Having said that, I would like to thank you again, OncoAlert, for giving me the opportunity to present also this year some of the main topics on breast cancer and radiotherapy issue. I would like to thank you very much.